Hello.
Good afternoon, sir. I can hear you. Shikha, sir, I can hear you.
Sir, yours is mute, sir.
I can hear you. Hello.
Hello.
Good afternoon, ma'am.
Good afternoon, sir. Good afternoon, ma'am.
Good afternoon.
And good afternoon. Dr. Anand, I think we can start because it's already 2:03.
Yeah, I have joined. I'm
So
sorry.
slowly people will join, no worry.
Yeah,
We can
yeah.
start.
Good afternoon.
Because I'm sure the speakers are there, ma'am is already there, everyone is there. So attendees will join. We can start it.
Okay, sir. Okay.
Ma'am, what do you say? Already
Yeah.
3 minutes over.
You should stick to that monthly.
Yeah. Okay. Thank you, ma'am.
So, good afternoon, all. Welcome back to our afternoon session of the first day. And the first session is on neurological and developmental disabilities, cerebral palsy, global developmental delay, and epilepsy. It's a 2-hour session. First, we'll have the neurological development disabilities, cerebral palsy, and global development delay for 1 hour, and epilepsy for the next 1 hour. And it is by Saurabh Chopra. And the session is moderated by Dr. Shigar Kumar and Dr. Gurwant Kirle. So I welcome both of you to this program. Dr. Shigar
Dr. Anand, Dr. Saurabh is there on the platform?
join, I think so.
Okay.
So actually, he's a very busy practitioner in Apollo. Maybe he's not able to join.
I spoke
It's
to his
okay.
assistant.
Let us
Yeah.
go ahead.
Dr. Shigar Kumar is a diligent pediatrician with strong observation and communication skill, specialized in identifying and managing treating children with special healthcare needs. About 35 national and international publications and co-authored 4 textbooks and serving as a White's Dean. And dedicated to us intensive discussion with different groups and societies regarding the growth and development of special child and special focus on sports industry and behavior management among children of all age group. We welcome you, sir. Dr. Gurvankir Lehi is a professor and head department of Government Medical College and Hospital, Chandigarh, active member of ISPPD, SKPPD, IDR, ISDR, NAMS, and ISDT. Fellow of ISDR, ISPPD, ICD, and Pairi Pochard Academy. Recipient of prestigious Star Periodontist Award by ISPPD, holds leadership role including Executive Committee member of ISPPD, Vice President IDA Chandigarh branch. Contributed to the textbooks, delivering guest lectures, and published around 65 plus research articles. Reviewer and editorial board member for the reputed scientific journal. So we welcome you, ma'am, to this program.
Thank
Thank you,
you.
ma'am, to introduce the speaker.
Hello, Hanji, good afternoon. It is a pleasure to introduce Dr. Saurabh Chopra. He has done his MD in pediatrics and he has done a fellowship in pediatric neurology from Mumbai, and he is also a Bill Marshall Fellow in pediatric neurology and complex epilepsy, which he has done from a renowned Great Ormond Street Hospital in London. He's also done Rats of Tobruk Epilepsy Fellowship from the Royal Children's Hospital, Melbourne. He's worked as assistant professor at MP Shah Medical College, Jamnagar, and also as associate professor at Subharti Medical College, Meerut, and has clinical experience in some of the leading hospitals in UK, Australia, as well as Delhi. And now he's working as a senior consultant pediatric neurologist at Indraprastha Apollo Hospital. Now I would request Dr. Saurabh Chopra to start with the presentation. Thank you.
Hello everyone. I would initially like to thank the organizers, especially Dr. Morsmi Madam, for having given me this major responsibility to deliver almost 120 minutes of content. So without wasting much time, let me start with my presentation. So initially, I'm going to talk about neurodevelopmental disorders. So the objective is to introduce you to the basic knowledge of children with neurodevelopmental problems. I'm sure most of you would be having significant awareness about these conditions, namely cerebral palsy and global developmental delay. Also, how these conditions affect the overall health and the care for the child, and how these particular developmental conditions will affect the dental practice, the challenges they bring, and how to overcome those challenges. So let's begin with a quick overview of development. The development of a human newborn is quite significant, in the sense that when we as human beings are born, we are quite helpless. Our brains have very, very minimal functions. Like a little baby would basically cry for help, and that cry would signify anything that might be disturbing the baby. It may include physical disturbance, hunger, irritation, illness, and we have to guess and find out. And mothers are quite good detectives at finding out what is wrong with their kids. But that's not the case with animals. Animals are born with significantly functional brains. An animal, as you can recall, most animals would be walking within hours of birth, and they are quite well equipped to handle many things in the environment. Unlike human newborns, This probably is because of the reason that our brains are much more advanced, and so if they actually get reasonably developed before birth, it would physically become very difficult for the baby to be born because our heads would be quite large. So development in humans is an important aspect that is not only useful for medical care, but even useful for education and schooling and other activities that we get our kids to do, because it is only according to their developmental level that a child will be able to enjoy certain activities, and only according to the developmental level they would be able to cope with specific medical procedures and care. So development is divided into various domains. So there is the physical domain, that is the gross motor development, your sitting, walking, etc. Fine motor development, mainly use of your hands to do fine motor manipulations, as well as speech, language development, and social cognitive development. Now let's look at these aspects. So as far as the gross motor development is concerned, our gross motor development progresses from above downwards. So that actually correlates with the areas of the brain that get myelinated and the areas that gradually take over control of various parts of your body. So initially the young baby, starting at about 2 to 3 months, will start holding their head. By the time they are 5 to 6 months, their head control is quite mature and stable. And by this time, they start sitting a bit with support. And by the time they are 7, 8 months old, their sitting is quite stable. And gradually they progress to standing with support, and then finally walking, running, jumping, etc. as they grow older. Most of our gross motor development gets completed by 1.5 to 2 years of age, except for certain minor things that are left for later age. Now coming on to the fine motor development. As far as the fine motor development is concerned, it is basically the use of our hands. And when we are born, when human newborns are born, the fists almost always remain closed. Gradually, as the child grows, the fists open. The child starts keeping their hands open most of the times. They start exploring the environment with the hands. They will try to reach out for human faces, touch them. Initially, that trying to reach out would be quite inaccurate, and they will miss many times. Trial and error will bring them better control. Finally, they'll start reaching with both hands and holding objects, and then it becomes more mature. They start holding objects with one hand, and then it gets even more mature. Their grasp, rather than a grasp which is palmar in nature, becomes more fine, so that for smaller objects they will start using their finger and thumb tips to hold. And as we grow older, our fine motor control becomes much better, and dentists probably are among people who have really good fine motor control on their jobs. Now coming on to the social, language, and cognitive development. This kind of is interrelated, so I put it together because your cognitive development and your speech, language, and social development goes quite a bit hand in hand. So even as a newborn, children will calm down when someone cares for them, someone carries them. Just touching them and talking to them in a calm voice will soothe them. Gradually, as the child grows older, they try to start making contact in the form of eye contact, and they will smile in response. And that is when taking care of the child becomes a little bit easier for the parents, because they will get this satisfaction of having responses from their baby. Gradually, they will start understanding the world around them. If in a very young child you show them an object and then suddenly hide it, they will really not know where the object went. And gradually they will know that objects are permanent, so they'll start enjoying things like peekaboo if you kind of hide your face and then bring it back to the baby. The baby knows that the face is not seen, but it is there, and so will wait for the face to reappear. As the child grows older, they will start recognizing their name and then gradually understanding words, as well as start making meaningful words, using sentences, and even relating short stories of what happened during the day. As one grows older, into a young teenager, abstract thinking starts appearing. We can understand things that are not really that real. So complex physics and complex maths are taught only in older classes after 9th or 10th standard, because that is the age when we start understanding those concepts. And finally, as we grow much older as adults, our cognitive abilities become much better. We can, as adults, we can take groups and make big research projects and really progress science, so to say. Now, after having understood the various domains of development, what is global developmental delay? Global developmental delay is something that can be labeled if more than one domain is affected. If it is only a single domain that is affected, then obviously it's a specific type of delay, whereas if multiple domains are getting affected, then one can use the term global developmental delay. Now, this is a very broad-based term, and so it can have lots and lots of causes. Basically, your development, your skill development as one grows older is something that reflects your brain's development, and anything that causes any problems with the brain will affect the development. So the insults to the brain can be toxic in nature, like fetal alcohol syndrome, exposure to various medications during fetal life, inborn errors of metabolism like phenylketonuria can also affect the brain's development. And that is why recognizing inborn errors of metabolism as early as possible is very, very important. And another thing that is important to be recognized early in life is congenital hypothyroidism, because both these inborn errors of metabolism as well as congenital hypothyroidism, if treated early enough, we can preserve the brain's function and prevent the development of delays. Various genetic causes are probably the most common causes of developmental delay. That is chromosomal, like Down syndrome, and copy number variants. Now, with the advancement of genetic testing, copy number variants are becoming very, very common as causes of global delay. By copy number variant, I mean there are short areas in your chromosomes that might be deleted or duplicated, and these can only be detected by more advanced techniques like chromosomal microarray. The older techniques of karyotyping cannot detect these sorts of problems. And then there are more specific genetic issues like Rett syndrome and Fragile X, which may be the cause of delay. Also, any severe systemic disease, a disease that is not directly affecting the brain, but is causing systemic problems, can cause significant developmental delay. So, severe congenital heart disease, severe renal diseases that start in early life will cause global delay, because the child is so sick throughout their early formative years that the development just cannot take place properly. But here, once we are able to overcome the underlying disease, the brain tends to bounce back and the development tends to improve. Also, significant emotional deprivation and neglect can also cause global delay, because our development is not just based on our genes. Our development is a combination of how good our genes are and how great an environment the genes get to express themselves. So if we have a very good set of genes and we get a very good stimulating environment, the human baby will do really, really well. Whereas any one of those two, if they get affected, the development can really take a hit. Now, understanding the various specific developmental delay. So, if you have developmental delay mainly in the motor domain and rest of the domains are doing well, one will start thinking of causes like cerebral palsy or neuromuscular diseases. Muscular diseases and diseases that affect only the nerves will cause problems in motor development. Whereas if there are problems which are relatively isolated in the speech language domain, then autism spectrum disorders become probably the most important cause in this group, although there are other causes as well. Here I have written about isolated speech delay. Isolated speech delay is when a kid is understanding language well, but the speech gets delayed. This is usually a less worrisome issue, but may indicate that there are some local oromotor problems, or sometimes even things like getting exposure to multiple languages at a very young age can also cause isolated speech delay, because the child is understanding so many things that they tend to speak a little later. In fact, my own son, when he was very young, was exposed to at least 4 different languages and started speaking a bit late. So that's probably the least worrisome of the speech delays. Now, talking about intellectual disabilities or intellectual delays, these can be stratified as borderline intellectual delay when the IQ is between 90 to 80, or it can be a definite intellectual disability when the IQ falls below 80. And then there are specific learning disabilities. These are specific learning disabilities are the ones where the IQ is normal, that is, it is between 90 to 100, but the child still has problems understanding concepts that may be specific to, say, maths, known as dyscalculia. They may have problems just with writing, dysgraphia. They may have problems just with spellings. Most of us struggle with English spelling sometimes. But if we struggle with lots and lots of spellings, that also is a type of specific learning disability. Now let's look at the common neurodevelopmental problems, the individual conditions. So among them, I think the most common ones that we face in our day-to-day practice is cerebral palsy, especially in our country, where neonatal care and perinatal care still needs improvement. Cerebral palsy is quite common. What does it mean? So cerebral means your brain, and palsy means paresis or weakness. So any motor issues that are caused by brain-related problems is cerebral palsy. So how does our brain control movement? So there are parts of the brain that will plan out movements, and then there are certain areas of the brain that will be connected to specific parts of our body. So when I want to stretch out and pick up a cup, my motor planning areas will plan, okay, the cup is this far away, and for that I would need vision and various other sensations to be intact. And that planning will occur, and then the specific areas of the brain that control the hand muscles and the shoulder muscles will then start getting activated, so that my hand will stretch out and hold the cup. And how does that signal reach there? So the signal then from the brain, that is the cortex of your brain, passes on to the basal ganglia. The basal ganglia are the areas which smoothen out movements. And it also requires input of the cerebellum, that is the area in the backside of your brain, this part, which also is very important in judging distance and kind of making the movement accurate. And all these areas put together will then finally send the highly modified but highly accurate signal to your muscular system. And how does that reach there? It reaches through the spinal cord and then through your peripheral nerves all the way to your muscles. So anything in this circuitry can cause problems with movement. So neuromuscular problems, that are problems with the muscle or the nerves, can cause it. Spinal problems, that is myelopathies, can cause problems with movement, and brain related problems, specifically issues that affect the motor system, can affect your ability to control smooth movements. So only if the brain is the cause of these movement related problems, we would call it cerebral palsy. This is again a bigger diagram showing the sort of frontal lobe in the front, the occipital lobe behind. So it is the posterior part of the frontal lobe which is responsible for motor control, whereas it is the parietal lobe which is responsible for your sensations. And finally, it is the deeper areas of the brain, that is the basal ganglia, which will smoothen out movements, whereas the cerebellum, which will help to make the movements more accurate. So finally, defining cerebral palsy. So cerebral palsy, as we all know, is again an umbrella term. It is not a single diagnosis, and it forms a broad group of conditions that affect basically your physical abilities, that is ability for movement and posture. This may be due to damage to the brain or malformation of the brain, and usually the damage has to occur in the early life, that is the age at which motor development is taking place. So the first or second year of life, or just before birth. One more thing I would like to stress, that although cerebral palsy is a term that is used only for motor related problems, but except for the most mild forms of cerebral palsy, most other patients will have comorbidities in the form of intellectual disabilities, epilepsy, and problems related to other brain areas. So they may have vision related issues if the sensory areas are involved. So looking at the causes of cerebral palsy, again, they are quite similar to the causes of global delay. That is, either the brain's development is affected by your genes or due to any damage sustained by the developing brain. So genetic causes may be single gene disorders, which lead to massive malformations of the brain. It can include maternal infections like torch infections, chickenpox in the initial trimester, or nowadays even Zika virus can cause significant brain insults. Maternal drugs, so exposure to certain medicines and toxins during pregnancy like phenytoin or alcohol can damage the brain. Similarly, the damage can occur after the brain has been formed. So this may include hypoxic ischemic insult, hypoglycemia. Again, hypoglycemia is quite common in our country as a cause of severe neonatal morbidity and long-term insult to the brain. Also, your direct brain infections like meningitis, encephalitis, head trauma, as well as strokes can cause cerebral palsy in the long run. So now understanding what are the various types of cerebral palsy. So if the cortex, that is the outer layer of your brain, gets affected, which includes your motor planning areas as well as the specific areas that control different body parts, then usually it is spasticity that develops, because that is the kind of movement abnormality that forms. What is spasticity? Spasticity is basically a form of hypertonia. The muscles of your body become excessively tight, and they have what is known as a clasp knife type of, that is, as you see knives, those Rampuri chakus of older generation films, which have this sort of initial effort, but then a sudden let go. And that is what happens to the muscles. So any rapid movement of the muscles will cause them to become very, very tight. And if you want to move the muscles of a child with spastic cerebral palsy, one has to do it very, very slowly and gently. Otherwise, they'll become extremely tight and moving them will become very difficult. Also, the white matter damage to the pathways of your brain will cause spastic type of cerebral palsy. The other type of cerebral palsy is dyskinetic. Dyskinetic means, as I said, that the basal ganglia or the deeper gray matter is important to smoothen out your movements. If there is damage to these areas, we get dyskinetic type of cerebral palsy. Now, dyskinesia means it is either dystonia or hyperkinetic type of movement. So by dystonia, I mean that they will be tight, but the tightness is different from spasticity. In spasticity, it is a clasp knife type of tightness, whereas in dystonia, they will have these torsion movements. That is, their body will get twisted in very abnormal sort of movements. I will show some videos for you to have a better understanding of things. Or they may be hyperkinetic. That is, even if they try to do a smooth movement, just move their arm from one point A to point B, they will have these sort of rapid, sort of jerky movements, and their arms and legs may be all over the place. Whereas finally, the last type of movement disorder that one sees in cerebral palsy is ataxia. That is due to the affection of the cerebellum. As I said, the cerebellum is very important in making the movements very accurate. So when, say when we are running or when we are doing any rapid movement, our sensory system is not designed to be that fast, right? So if I'm running at the maximum capacity, my legs are flying out in space and time, but my sensory system there's a lag. If there's any sensation from your leg, it takes time to reach your brain, but your cerebellum calculates and the cerebellum can judge at that particular time, taking in the lag, where would your body be in time and space. So when I try to grab something, suppose I'm trying to kind of grab this camera, I'm trying to point out the camera, my finger is very, very accurate, it directly reaches there. But in the absence of a good cerebellar control, when I reach near, my finger will start swaying because I can't judge the exact place, and that is known as ataxia. Now, the cerebral palsies can also be classified depending on how they are distributed in your body. So sometimes the damage to your brain can be very, very small. So it may affect only some part of your body. So cerebral palsies can be monoplegic, that is affecting only one limb. Whereas as you can see in the cartoon, it can be hemiplegic, that is affecting only one side. Sometimes hemiplegic cerebral palsies usually occur due to vascular problems because the vasculature that provides the brain with fresh blood is divided on each side. Whereas at times the distribution of the cerebral palsy may be diplegic. Diplegic means it is the lower limbs that are much more affected as compared to the upper limbs. And that may be because it is the central areas of your cortex that are affected, or more commonly, as occurs in premature infants, it is the white matter that is much more affected, and that also leads to diplegic type of cerebral palsy. Whereas if large areas of your cortex or white matter get affected, then you have a quadriplegic cerebral palsy. That is, there is significant affection of all the four limbs. And when there is significant affection of all four limbs, you would also have affection of truncal control. That is, your trunk control will not be that good. Whereas diplegics can most of the times have reasonable sitting. Quadriplegics find it very difficult to sit. Also, swallowing and bulbar control gets affected in quadriplegic cerebral palsy because in the other types, there is good bilateral innervation for your bulbar control. So, if lesser areas of your brain get affected, you will not have swallowing difficulties. whereas dyskinetic cerebral palsies that affect the basal ganglia usually are affecting the whole body, and ataxia also tends to affect the whole body because these are small structures and they control even if there's a small area of damage, it tends to affect the whole body. Now let's look at some videos. So this first video is of a child. Can you see that she's keeping her right hand in a specific posture, whereas she's using her left hand quite well. She's also having differences in the way which she uses her legs. So on one side, so here the hand is kind of in a spastic posture. She's kind of holding her fingers in a fairly stiffed out posture. Now looking at this second video, so this last example was a hemiplegic cerebral palsy. Now looking at this second video, this child has very severe movement disorder in the form of a dystonia. The child is completely arched towards his back. He's completely like this, almost like a bow and arrow. His body is completely arched out, and this is a form of severe dystonia, where his body is going into unusual and abnormal postures. So this is not spasticity, this is a form of dystonia. It's probably a severe form of dystonia affecting the whole body. This is a slightly less severe form of dystonia where the child is able to move, but you can see that when he's trying to see the toy and approach the toy, his hand goes into funny postures, it goes back, and he's not able to really approach the toy. And if you look at the mouth, there is a lot of oromotor dyskinesia. His tongue is moving in and out, and his mouth is opening up, although that's not what he's wanting to. But whenever he gets excited, the dystonia becomes more. Whenever he is not excited, his dystonia is less. That is how dystonias behave. They become more when you try to move, and they become less when you are calm and quiet. So these will help you plan dental treatments, because keeping the child as calm as possible would help to manage their movements and help to get better cooperation from them. So last part, which I think all of us should understand, is how is cerebral palsy managed. So cerebral palsy, the mainstay of management of cerebral palsy is recognition as early as possible, even sort of preemptive recognition. So any child that goes through a bad neonatal or perinatal period should start physical therapy by a trained professional who knows how to deal with young babies. So physical therapy is probably the most important thing, because when your brain is developing, you can modulate the brain's development in the right direction. Whereas if that is not done, the brain will start having these abnormal connections leading to spasticity and movement disorders. Whereas if you start therapy early, in many children, you can prevent all those things from developing. Secondly, medications. Medications help to reduce the tone in cerebral palsy, as well as they may be helpful in various other problems that children with cerebral palsy may be facing. Once the child grows older, they may need either orthopedic interventions or neurosurgical interventions, as well as things like Botox injections to reduce their spasticity. Orthotics and supportive care goes a long way in helping children with these physical issues, and that's why it's very important. So having a team approach is really important, where all the members of the team communicate with each other. I will have my therapist telling me that, look, when you started medications, the tone just went too down and we are not able to work with the child. Please reduce the medications. I will refer my patients to the orthopedician, who will then assess and see if orthopedic interventions have to be done right now or a bit later. And the orthotics really help in almost every stage. Now, one last thing in the management of cerebral palsy, there's a whole lot of noise and hope around stem cells and stem cell treatments for various neurodevelopmental disorders, not only cerebral palsy. And that is why I want all professionals dealing with children with special needs to at least have a basic idea as to what is the current reality. So the current reality is actually very promising, but there is a lot of misinformation going on. So stem cells basically are cells that can develop into any type of cell. So obviously they can be made to develop into brain cells. Not only that, technology has reached a stage where you can actually form these small brain lumps, and you can actually make the various layers of the cerebral cortex in the lab. So we are really reaching into areas, in fact, in other organs like hepatic and renal. People are in stages where you will probably have organs being harvested in the lab. As far as the brain is concerned, I think we are still far, because the brain is a very, very complex structure. Now, as far as cerebral palsy is concerned, how can stem cells be helpful? So the current research, that is just, these are all publications in the last few years, there's a whole lot of research that has said that when there is acute damage to the brain, so if you have a neonate who has undergone severe hypoxic ischemic insult, if you give stem cells at that very stage, within hours, that is within 24 hours to 48 hours of that insult, it can really change the way the brain copes with that insult, and it can improve outcomes. But once the brain has taken a hit, and it's an old injury, so it's a gliotic injury where the healing process is already complete, at that stage, stem cells are not useful, and there is enough research to say that they are not useful. There have been so many animal models, and it has not been found useful. And there have been a couple of human studies as well, and it has been found that in the chronic stage, there is no usefulness of stem cells, because the usefulness of stem cells is just the modulation of how the body copes with insults, whereas in the late stage, the aim is to kind of repair and regenerate the brain, which we cannot do as for now. So there is a whole lot of dark reality around stem cells. There are lots and lots of so-called stem cell centers all over the world, including every major city in our country, and most of us fully agree that these are not ethical, and they do not provide scientific care, and sometimes can cause harm rather than any good. So one should be clear that any center that charges money to provide stem cell therapy is, in today's age and date, probably not ethical. Now, coming on to the next. So after having learned a bit about cerebral palsy, let's look at some of the other developmental disorders. Although neuromuscular disorders per se don't form part of global developmental delay or developmental disorders, but I've still included them because having some basic knowledge is important for dental practitioners. So the common neuromuscular disorders are Duchenne's muscular dystrophy and SMA. So these are all these conditions either cause progressive weakness of your muscles, or they can cause static weakness of your muscles. So they may have a myopathic phase where the facial muscles are weak and kind of drooping down. The eyelids are drooping down. Unfortunately, I can't show them in the pictures. Many children with neuromuscular disorders will have breathing issues and sleep disordered breathing with carbon dioxide retention. Till now in our country, the recognition of breathing issues in neuromuscular disorders is very, very low. I keep referring my patients to respiratory specialists But most patients will not go and not get themselves tested because it is a problem that is not clearly recognized by the parents, and it is also poorly understood by non-pediatric neurologists. That's why if you're thinking of using nitrous oxide sedation or any other form of sedation in a child with significant neuromuscular weakness, one should be a bit careful and probably check with their treating physicians. Some of the children with neuromuscular conditions can have cardiac issues, especially children with Duchenne's muscular dystrophy will have significant cardiac issues as well, because the heart basically is also a muscle, whereas others like SMA may not have any direct cardiac issues. That's why they will also, many of these children will have problems in their facial and dental development because their neuromuscular forces are not going in the right direction. Now again, the next that I've included is Down syndrome. I think it's a very well recognized disorder, and even in our country, most children with Down syndrome would know their diagnosis, even if they may not have been tested, because it's literally something that can be recognized by looking at the child. One thing that I would like to emphasize here is even children with Down syndrome are hypotonic. They will have breathing issues. Many of them may have sleep disordered breathing as well. So while sedating, one should involve the treating physicians. Not only that, some of them, not all of them, some of them may have atlantoaxial instability. Now, what do I mean by that? So your upper cervical vertebrae, the upper two cervical vertebrae are the atlas and the so they both form a very peculiar joint. There's the odontoid process of the second cervical vertebrae that goes right into the loop of the first cervical vertebrae. This is how they are positioned against each other. And your spinal cord is passing through the loop. So when your atlantoaxial joint is not stable, there can be unnecessary movement of this odontoid process, and that can compress the spinal cord, which can be quite a serious issue. And so, unless we are sure, children with Down syndrome, one should be careful in manipulating their neck. Now, looking at this set of videos of Rett syndrome. Rett syndrome is another neurodevelopmental disorder that is probably not as common as the others, like Fragile X and Down syndrome, but is also quite easy to recognize clinically. It's quite easy. So you can see this first video of the same child. Both the videos are of the same child in more or less the same situation, but 1 year apart. So this is the video 1 year ago where the child is playing in the bathtub and quite nicely using the hands to pick up toys. Whereas when we look at the second video, after 1 year, the child has started only using the hands to put in the ball. The child is doing exactly the same thing again and again and again with the hand, and has actually stopped using the hands for other purposes. This is a very, very classical feature of Rett syndrome. So along with developing social and language regression. So this child was brought to me basically because there was social and language regression. The child was not getting involved with the mother as much as 1 year ago. Along with that, there were lots of these stereotyped hand movements. The stereotyped hand movements may vary from child to child. Some of them may start with something like this. Some of them may start with something like this. In this particular case, the child was repeatedly putting the hand in the mouth and associated with loss of use of the hands. So this is what is Rett syndrome. Rett syndrome also besides having regression of hand function and regression of social and communication, will have lots of behavioral issues, and they may also have lots of sleep issues, including sleep disordered breathing and breathing abnormalities. So one needs to be careful with them. Finally, fragile legs. This is again a relatively common and relatively easier to recognize genetic cause of developmental decay. They have prominent ears, sort of sharp pointed chins. They have intellectual disability, and they are actually not picked up in the kind of testing we have nowadays. So nowadays we have broad-based genetic testing because many genetic disorders have a lot of overlap. So besides something like Down syndrome, it is not that easy to pick up other disorders just by examining and taking a clinical history. So for that purpose, we have broad-based genetic testing where we will test a lot of genes at one go, or we will test almost all the chromosomes for major deletions or duplications. These broad-based tests may miss things like fragile X because it's a copy number expansion. That's a very specific type of genetic issue which can only be picked up by specific testing. Now, after having an overview of the various neurodevelopmental disorders, I would just give a brief idea about the medications that we may be using for children with some of these disorders. There may be medications to reduce the tone, that is the spasticity or dystonia, or there may be medications to modify their behaviors because many of them will have lots of behavioral issues. And there may be medications to help with their sleep, like melatonin. So what are the implications of these medications? A lot of these medications can be quite sedative, and benzodiazepines, tizanidine, clonidine are sedative. Even some of the newer antipsychotic medications, although they are less sedative as compared to the older generation antipsychotic medications, but even then they may have sedation. Even some of the medications used for ADHD may cause a bit of sedation in some children. Especially if the child has been put on some of these medications recently, the sedative effect may become quite added to their sort of dental sedation medications. Also, a lot of these medications may cause hypotonia, especially the medications that are specifically used to reduce tones. So your benzodiazepines, which are actually commonly used. So midazolam is commonly used for dental sedation, as I'm aware, and that too can reduce your tone further. So if a child already has significant hypotonia, one should be a bit careful, especially with neuromuscular disorders, because they can be quite sensitive to anything that reduces tone. Besides this, medications that are used for behavior management can actually help some of the dental procedures if used cautiously. So many children with autism may be much calmer by using some of the newer antipsychotic medications. Many children with behavioral problems may actually sleep better if they are given melatonin along with it. Even clonidine sometimes is very useful to sedate children with a lot of hyperactivity, because clonidine has this specific mechanism through which it also reduces hyperactivity. Now, finally, let's just have a brief overview of what the implications in dentistry might be. I'm sure other prominent speakers would be talking about this. So besides, as you all know, most of these children with special needs will have increased morbidity as far as their dental health is concerned. They may not have adequate developmental level to be able to cope with dental treatments. They may have lots of specific issues, like children with cerebral palsy are very, very sensitive to stimulation. They will become very tight. Their spasticity may significantly increase. They may go into a severe opistotonic arched posture if they are given excessive stimulation. So one has to be very gentle and careful while managing them. And many times we may have to use some or the other form of dental sedation to help them cope with the procedures. Lots of them will also have a lot of swallowing difficulties, not only cerebral palsy, but some neuromuscular problems like your SMAs will have swallowing difficulties. A lot of children with chromosomal problems will also have swallowing difficulties. Sometimes they may have local difficulties like Down syndrome may have a large tongue, and so their bulbar control may not be that great. In some cases like Pierre-Robin syndrome, the jaw will be very small. So their tongue and other tissues will start encroaching their bulbar areas, and that will lead to a lot of breathing as well as swallowing problems. So this, I think, provides a bit of an overview on neurodevelopmental conditions. And the next part of my talk, which I have recorded as a separate lecture, will talk about seizures and epilepsy. With that, I would like to end this presentation. Thank you all for your patient listening. Hello, everyone. I would like to thank the organizers, including Dr. Moshmi, for giving me this opportunity to present on epilepsy. Epilepsy in children with special needs is a common problem, is a relatively common problem, and all health professionals working in the field of children with special needs should have at least some basic working knowledge about seizures and epilepsy. With that, I would like to start the presentation. So let me share my screen. So in this talk, we would not only talk about the basic knowledge on seizures and epilepsy, but also what specific care and precautions should one take with children who are known to have seizures, and also to learn how to provide first aid just in case a seizure occurs in the clinic. What are seizures and what is epilepsy? The brain is basically like a biological computer, and it works on the basis of electrical conductions. As the one would remember from physiology, all the neurons communicate with each other through biological electrical signals. When the neuronal discharge becomes abnormal and excessive, and this happens suddenly in a highly synchronous manner, that leads to what is known as a seizure. And that leads to variable clinical manifestations which are recognized as seizures. Now, this is a very theoretical definition, but looking at the practical aspect of things, when there is an abnormal discharge occurring from a large number of neurons, the child's brain will start firing in an uncontrolled manner, and that is what will lead to a seizure. The seizure manifestations will vary depending on the part of the brain that the seizure is involving. If it is the part that controls movement, you would end up seeing jerking or stiffening of the body. Whereas if it is the part of the brain that deals with sensations like vision sensation, then the child may hallucinate and see some visual phenomena. Children will come and say that they see a ball of light that's growing larger and it seems like a fireball is coming towards them. Sometimes they will see multiple colored balls. So that depends on which part of the area is getting involved. Similarly, if areas controlling emotion are involved, it might be a sudden emotional change. And sometimes the behavior of the child will completely pause. It will be like a behavioral arrest. And at times it may be involving the autonomic part of the brain, causing vomiting, heart rate change, and many times multiple manifestations may occur together because the brain is a highly conductive organ. And so once the seizure starts, it tends to spread everywhere in the brain. So with that basis, we first would like to classify seizures into the two basic types. The two basic types of seizures are basically depending on their onset. So if a seizure is focal onset means it starts in a very restricted area of the brain, and then it may or may not spread further. If it starts in a very restricted area of the brain, the manifestations will also be restricted to that part of the brain. Whereas if it spreads later on to other areas, it will be like a secondary spread. Some seizures may have a generalized onset. By generalized onset, I do not mean that every part and every corner of the brain is involved, but by generalized, I mean that very large amount of cortex on both the sides, that is both the hemispheres, gets involved right at the onset. And so clinically, as well as on investigations like EEG, we cannot label that seizure to be starting from a particular area. And in that case, it is known as a generalized onset. It is important to divide seizures into two basic categories of focal and generalized because it has lots of prognostic, therapeutic, and even diagnostic implications. Now let's look at this video. This video is of a neonate. Can you see the left upper limb of the child having these very, very subtle, slow jerks? But if you see carefully, the jerks have a fast component followed by a slow relaxation, a fast contraction followed by slow relaxation, and the jerks are occurring in a rhythmic manner. They are occurring in a periodic rhythmic manner. So this is known as a clonic jerking. And since it is involving just one part of the body, that indicates it is involving mainly the part of the brain that controls the movement of this particular limb, right? So this indicates that this seizure is a focal onset. So how will you determine whether a seizure is focal onset? You will determine basis of if it starts on one side of the body or just one part of the body, as we saw in the video. If there is turning of the head towards one side or turning of the eyes towards one side, or after the seizure finishes, there may be paresis of a particular part of the body. The paresis is because the part of the brain that controls or sends signals to that particular part of the body gets exhausted by the seizure, and for about 10 minutes or half an hour or so after the seizure, the brain area is so exhausted that it does not send any signals, and so the area can get temporarily paralyzed. Sometimes the patients themselves are conscious during the seizure, and so they will be able to remember things that happened during the seizure. So the patient might be able to say that he had a occipital lobe seizure by telling you that the person had a visual sensation before they lost consciousness. Also, it is important to ask how the event started and what happened before and after, because sometimes the history givers may not find it relevant to tell you the most important part of the history. They might fixate on the part that they got worried about. So just giving you an example, there was a child in which the parents just told me that the child came to the kitchen, fell down on the floor and started jerking all over. Now that sounds like a generalized seizure because all the body parts started jerking together. When I asked the child, what was he doing before this started? The child was actually having a bath. He came out of the bathroom without any clothes, ran towards the kitchen in search of his mother, and then he actually fell down and started jerking all over. When I asked the child, why did he run out of the bathroom without clothes? He said that a ball of fire was coming towards him. Basically, he was having a visual sensation of light in the form of a round shape, which was increasing in size, and that is why he felt so. With that history, one can actually say that the seizure is focal and not generalized. Now, coming on to the more generalized seizures. So one seizure we saw in the first video, which was blurred, where the child was having jerking of all the limbs. That is a classical generalized tonic-clonic seizure. But there are other types of generalized seizures as well. So looking at this video, this child is actually undergoing an EEG. And during an EEG, we ask them to overbreathe. We ask them to have deep breathings to induce a particular type of seizure. And you can see that in this child, the seizure will get induced. So the child is breathing nicely, and then suddenly you will see that the child starts staring. The child is not responding. There's no voice, but someone is trying to talk to the child, call the child, but there is no response. The child is just staring into nothingness. And this is what is the classical arrest of behavior. The child's behavior is completely arrested. And there is no movement. It is almost like a statue. But the child is not having any jerking, not having anything that is commonly known as part of generalized seizures. But this too is a generalized seizure and is known as an absence seizure. Absence seizures are probably the mildest form of generalized seizures because the children do not lose their posture, do not fall down. It is just that their behavior completely stops. Just for a few seconds. It is not this long lasting. It usually lasts about 5 to 20 seconds. Now looking at this next video, here again the child is having an EEG, and during the EEG we also give flickering lights into the eyes of the child. The purpose of that is to induce abnormalities on the EEG as well as induce seizures. Now, as you can see in this child, while she was having these lights, she started jerking. Can you see this almost shock-like jerks that the child was having? These shock-like jerks are also another form of generalized seizure, and they are known as myoclonic jerks. So we looked at focal seizures, we looked at generalized seizures. Now, let's understand the difference between provoked seizures as well as unprovoked seizures. Seizures can occur due to many acute causes. These are known as provoked seizures. So seizures can occur because the calcium levels fall down or the sodium level comes very down due to various causes that can lead to seizures. Infections of the brain like meningitis, encephalitis can also lead to seizures. Similarly, head injury and trauma can lead to seizures. But these are all provoked seizures. In children, there's a specific type of provoked seizure known as febrile seizures. These are seizures provoked by fever. Provoked seizures are common, but they don't really form the part of what is known as epilepsy. Epilepsy is a condition where a person has repeated unprovoked seizures, right? So this differentiation is important. Now, one more slide about febrile seizures. Febrile seizures is an extremely common condition. 5% of children below 6 years of age will have febrile seizures. So that's a huge number. Every week in all the major hospitals of the city and the country, we regularly receive children with febrile seizures. So, what is a febrile seizure? So, a seizure that occurs in the context of fever without any other triggering factor. So there should be no brain infection, there should be no metabolic cause, there should be no acute neurological insult. Along with that, there should also not be any history of previous unprovoked seizures, right? So if the child fulfills these criteria, then we consider it as a febrile seizure. And nearly all children will outgrow this tendency of having febrile seizures. So recognizing it is important so that we can reassure the family and we don't end up starting unnecessary medications. So the most important thing in the context of febrile seizures is to manage the acute episode. So the first stage for seizures is probably the most important thing that the parents and caregivers should know when a child is having febrile seizures. I will talk about the first state of seizures in the end of this lecture. So let's move on. So I was talking about focal and generalized seizures. Then I was talking about provoked and unprovoked seizures. And now let's talk about what is epilepsy. So as I was mentioning earlier, epilepsy is something which is defined as a tendency to have repeated unprovoked seizures. But there's another catch here. So I've written it is a group of conditions. So this is very important. Epilepsy is not one diagnosis. Epilepsy is a group of conditions. So multiple etiologies can give rise to this tendency to have repeated seizures. And so all these multiple etiologies put together can lead to epilepsy. So epilepsy is not a single condition, but it is a group of conditions. And understanding this is important because children in various severities of special need can have epilepsy. Now, this is a very theoretical definition. Practically, how do we define epilepsy? Practically, at least 2 unprovoked seizures, which are at least 24 hours apart, would fulfill the definition of epilepsy. Along with that, sometimes if we have just a single unprovoked seizure, but the EEG, MRI, or certain background testing suggests that if this child has had one seizure, the chances of repeat seizures are quite high, that is higher than 60%, then even that child would fall under the definition of epilepsy. Similarly, diagnosis of specific epilepsy syndromes. I would not talk about epilepsy syndromes because I think that would be beyond the scope of what non-pediatricians need to know about epilepsy. Now talking about the etiology. So as I had mentioned earlier, epilepsy is a group of conditions. So various etiologies can lead to it. Which are these etiologies? So it can be structural. By structural, what I mean is something that affects the structure of the brain. So something that can be detected on a brain scan. So the structural etiologies may include old injury or insult to the brain, which will lead to gliosis. Gliosis is the type of scarring that the brain undergoes after having an insult. So it can be a gliosis or encephalomalacia. Encephalomalacia is a term used when the brain matter is lost because of insult or injury and there is a loss of volume or an empty space filled with CSF left behind. So besides these physical or metabolic injuries, malformations of the brain can also lead to seizures. So malformations are usually occur in the perinatal period when the brain is forming, and various malformations can lead to increased tendency to have seizures. Along with that, genetic causes are a major contributor, especially in pediatric epilepsies. And now with advancing technologies in diagnostics of genetics, there is a huge explosion of knowledge of what various number of genes that can cause epilepsy. Along with that, chromosomal conditions like Down syndrome, Angelman syndrome are also associated with increased tendency to have seizures. Also, some infections of the brain like neurocysticercosis, which is the brain worm. It is quite famously known as the worm found in cabbage, although I think that's not the right description for the worm. But it's a common infection, especially in the northern part of the country, which leads to repeated seizures and epilepsy. And tuberculosis of the brain, which leads to tuberculomas, is another common infectious cause of epilepsy. Besides that, the lesser common causes include inborn errors of metabolism and autoimmune causes. Despite multiple investigations, sometimes the cause may remain undiagnosed, in which case unknown etiology is an accepted diagnosis. In fact, it is part of the classification as well. Because the brain is such a complex structure, we still don't fully understand some of the etiologies. And hopefully with time and advancement of medical science, this will improve. So now, although classification of epilepsies is not something extremely important for a dental practitioner to know, but having just a basic knowledge is always helpful. So first of all, I already told you about the classification in a stepwise manner. So now let's look at it as a whole. So the first step in classification of epilepsy is to classify the type of seizure, whether it's a focal onset seizure, a generalized onset seizure, or in some cases it might be an unknown onset because no one has seen the beginning of the seizure. Secondly, the etiologies. So I was just talking about the etiologies. So having that as part of the classification is important because nowadays with advancing knowledge, many seizures are targeted directly from the etiological point of view rather than the old pedantic sort of focal and generalized types of seizures. And then finally classifying the epilepsy type. That's whether the overall epilepsy is a focal onset, a generalized onset, or a combined, and as in some cases, it may be an unknown type of epilepsy. And finally, classifying them into epilepsy syndrome. And the last, but probably also a very important part that can be missed many times is comorbidities. Epilepsy may not be the only thing the child is having. So children with special needs many times have multiple issues and all of these issues need to be addressed. Just treating the epilepsy and stopping the seizures is not the end. It is just the beginning to making the life of the child more meaningful, not only as an individual, but for the family as well as for the whole society. So again, a basic version of seizure type classification. I think we have already talked about it. Now, next step is diagnosing epilepsy and seizures. So the most important thing to remember here is epilepsy and seizures do not have any diagnostic tests. The diagnosis is a clinical diagnosis based on history, home videos, and overall examination. So the so-called diagnostic test, which is a misnomer for epilepsy, is EEG. Why would I not call it a diagnostic test? Because it has a very high level of false positive as well as false negative rates. So almost 10% of normal children who never ever will get seizures can have an abnormal EEG, and almost 50% of children with epilepsy, that is, with clear-cut epilepsy, may have a normal EEG. So EEG is mainly supportive and not a diagnostic test. Abnormal EEG is not equal to epilepsy, and a normal EEG does not rule out epilepsy. So this is something that I keep emphasizing to all clinicians working with children with special needs, because this is something that is quite misinformed even amongst doctors. Another diagnostic procedure that we use in children with seizures is brain imaging. Nowadays, MRI has become the standard of brain imaging for children with seizures, except for very, very specific circumstances or where MRI is very difficult to get. MRI may be able to pinpoint the etiological cause. So, this is the classical neurocysticercosis or the brain worm. This is the classical sort of multilobular tuberculomas. This is an old stroke that has left a large area of gliosis. And this is a hypoglycemic brain injury in neonates that leads to posterior cortex involvement. Sometimes the etiological diagnosis is literally written on the face of the child or very easy to pick up in the examination. So here, if one remembers, there are neurocutaneous syndromes. Neurocutaneous syndromes occur because the brain as well as the skin are quite related to each other during fetal life. They both start from the ectoderm, and the brain actually forms out of an outpouching of the skin layers. And that is why sometimes if you have a particular malformation on the skin, it may be replicated on the brain as well. So in this particular syndrome known as Sturge-Weber syndrome, you have an extensive hemangioma on the face of the child, and this is associated with a vascular malformation in the brain, which can be detected on contrast enhanced imaging. Because of the vascular malformation, there is more contrast present in that particular area. At times, there are other neurocutaneous syndromes, like here, you have tuberous sclerosis. Tuberous sclerosis may also have enamel pitting. So that's another feature that may be there in the teeth of children with tuberous sclerosis. But their skin manifestations are quite easy to pick up. They have these multiple hypopigmented patches known as Ashley spots. And they have other skin manifestations as well. And the MRI will show these whitish patches on T2 weighted images. These are technically tubers. These are the tubers that define the tuberous sclerosis complex, and these lead to seizures. Now we have talked about the various steps of understanding what is a seizure, what is a provoked, what's an unprovoked seizure, what is epilepsy, what is the classification of epilepsy, and what are the etiologies behind epilepsy. Now let's understand the treatment part. Obviously, I don't expect dental practitioners to treat epilepsy, but having a basic understanding of treatment is important because it may have implications even in the oral cavity. So, and sometimes parents might ask their doctors, because dentists tend to meet their patients quite often and over multiple appointments. So parents many times become closer to a dentist than they are to the pediatric neurologist, because we tend to follow up our patients once in 3 months or once in 6 months. So just some basic things. As I told you earlier, epilepsy is a group of conditions. It is not a single condition, and that is why the treatment has to be individualized. Some types of epilepsies are self-limited, especially in children. In children, a lot of epilepsies are self-limited, and some of them, if the seizures are infrequent, may not require any treatment whatsoever, besides teaching the family acute management of seizures. The choice of drugs depend not only on the epilepsy type and the seizure type, it depends also on the age of the child, the sex of the child, the body type of the child, because there are some medications that will increase hunger, increase weight gain, and others that will reduce hunger and reduce the weight. So we have to balance it that way. Certain medications cause more problems in women and teenage girls as compared to boys. So we have to target our medication not only on the type of problem that the child is having, but the overall constitution of the child. So 2 children with the same epilepsy may be started on different medications. So the general idea among the lay public is that if we start anti-epileptics, it will be for life. My child will be hooked onto the anti-epileptics or will become dependent on anti-epileptics, which is not the case. But just Re-emphasizing the same point, since epilepsy is not a single condition, the duration of anti-epileptics may vary from child to child and type of epilepsy to another type of epilepsy. Unfortunately, the anti-epileptic drugs do not cure epilepsy, and this is true for alternate medicines also. And but the good news is that most children will grow out of their epilepsy as the brain matures, and so we are able to withdraw the anti-epileptic drugs with time. And that is why the duration is usually long. In most cases, the rule of thumb is that if the child has not had a seizure in the last 2 to 3 years, then there's a good chance that the child has outgrown their seizures, and a trial of gradual withdrawal of anti-epileptic should be planned. Here, I would like to emphasize that when a child is seizure-free for more than a year on anti-epileptic medications, if they are taking the medications regularly and they are seizure-free, the chances of seizures are quite low. So the child is actually in a good phase. So if you want to do certain planned dental procedures, that's a good time to do it. Especially procedures like orthodontic procedures, where there will be something in the mouth of the child that can dislocate during the seizure and cause aspiration risk. So that should be done with good communication with the family about the risk and choosing a period where the child is least at risk. Whereas when we start withdrawing anti-epileptic drugs, that is the time when the risk of repeat seizures increases. So child has been seizure-free for 2 to 3 years on medications, but the moment we try to start withdrawing medication, the risk increases. So something like an orthodontic procedure, if we are planning it, then maybe the withdrawal of anti-epileptic drugs can be postponed a bit, or one should wait for a year after withdrawing anti-epileptic drugs so that we have a good time without anti-epileptic drugs to judge whether the child's risk of having repeat seizures is high or low. So if after a year the child has been seizure-free, the risk becomes significantly lower. After withdrawing medications, the highest risk is in the first 3 to 6 months, and after 1 year, the risk is significantly lower. So that would be a better time to start such treatments. In some forms of epilepsy, we know they are self-limited, so the withdrawal of treatment might be much earlier than the 2 to 3 years mark. Whereas in other forms of epilepsy, like the classical example being juvenile myoclonic epilepsy, they practically require lifelong treatment, although they are easy to control. Just with good and regular dosing of medications, seizures in most patients of juvenile myoclonic epilepsies come under good control, and they have to be counseled to keep taking the treatment. Now, after this basic understanding of how epilepsy is treated and how the drugs are given and withdrawn, let's see some specifics about anti-epileptic drugs. So again, here I don't want non-neurologists and non-pediatricians to know details about which drug to choose when, but since you would be dealing with children who might be on anti-epileptic medication, so having some basic general understanding is important, because the list of these medications is ever increasing. This list is certainly not complete by any standards, but these are the commonly used medications. So there are certain medications that reduce our secretions. So oral secretions as well as sweat secretions can be reduced by medications known as topiramate and zonisamide, because both of these medications are derivatives of, they are type of diuretic derivatives, and that is why they reduce the secretion even in our mouth, and they can lead to dryness of mouth. Not only that, they reduce the sweat secretion as well. So especially in our country with such high temperatures, children may start having high body temperature because their body cannot lose enough heat by sweating. And this may be misinterpreted as fever. Secondly, the most prominent and well-known side effect of oral anti-epileptic drugs is gingival hyperplasia. And it can be quite bad at times. The drug that is most implicated for gingival hyperplasia is probably phenytoin, because that's a drug that is very notorious to cause it. But phenytoin is hardly used nowadays. In the private sector, its use is almost completely gone. To some extent, it is still used in the low socioeconomic group of patients who visit government hospitals. Other drugs that can cause it that are still in use is valproate. Valproate is probably the only other drug with which I personally have seen gingival hyperplasia, because valproate is also a drug that is used for prolonged periods and commonly. It's a very commonly used drugs. And I've had patients who have had really bad gingival hyperplasia, literally covering the whole teeth. And this is something that can occur due to valproate. The other two drugs, that is vigabatrin, is usually not used for very prolonged periods because it has other side effects. And so commonly we don't see patients who have had gum hypertrophy because of it. Ethosuximide is a drug that has been launched in our country very, very recently. So it's not even been a year since its launch. So up till now, we have not seen gingival hyperplasia because of it. But probably in the future, we might start seeing patients due to it. Here again, if there is gingival hyperplasia, I think you all know better than me how to manage it. But you might have to pick up the phone and talk to the pediatric neurologist or the treating doctor in an attempt to try to change the medication, especially if the hypertrophy is very marked and causing significant dental issues. Other drugs that are used can cause certain generalized side effects that can have oral manifestations. So one of the most dreaded side effects of anti-epileptic drugs is the Stevens-Johnson syndrome, also known as SJS in short. It's a dermatological emergency. It's probably the severest form of drug allergy, where one can have very rapidly progressive rash that can literally lead to erosion of skin and almost like a severe burns case. They are really bad, and so we always educate our patients about monitoring for these side effects. But sometimes in these side effects, that is Stevens-Johnson syndrome, is associated with involvement of the mucosal layer. So you can have oral ulceration, oral redness, the tongue becoming quite red and inflamed, and even the lips getting involved, along with generalized manifestations. So this is actually a drug emergency. It's a dermatological emergency, probably among the very few dermatological emergencies, and the person needs to be admitted almost immediately. So the drugs that are most implicated are some of the older drugs like carbamazepine, oxcarbazepine, phenytoin, phenobarbital, and lamotrigine. Lamotrigine is mostly implicated in Stevens-Johnson syndrome only when it is used with valproate, because that tends to increase its half-life, and so even if you stop the drug, it will take a very long time for it to wash out of the system. So that is why if you get a Stevens-Johnson syndrome, it will keep progressing till the drug washes out. Safer drugs that don't cause Stevens-Johnson syndrome are marked in green. These are some of the benzodiazepines and some of the newer medications. So sometimes the side effects of drugs may be misinterpreted by the parent. So there are children whose hunger may be reduced, their appetite may be reduced, and this may be attributed to teeth problems. So topiramate and zonisamide many times cause a reduced appetite, and sometimes parents may bring them to the dental practitioner thinking that they have dental issues, because children are smart. When they are not hungry and their parents are pestering them, they will come up with one or the other excuse saying कि दांत में दर्द हो रहा है, पेट में दर्द हो रहा है, and that is what children use, and the parents then will bring to the practitioner because their child is trying to fool them not to overfeed them. Other medications can increase the hunger, like valproate and carbamazepine and oxcarbazepine can increase hunger. So after having a very basic understanding of what side effects certain medications can produce and how they can present, just this last part about difficult to treat seizures and difficult to treat epilepsy, also known as drug-resistant epilepsy. So if multiple medications have failed, that is 3 or more medications have failed, then this child certainly needs an expert pediatric neurologist to intervene. They are not the kind of cases that pediatricians or general care doctors can provide. We have to carefully reevaluate those cases and provide certain specific options. Some of these specific options I have included here because it is important for all medical care providers to children with special needs to be aware of. So the first is the ketogenic diet. This is a highly specialized, medically supervised diet. Although it is similar to the fad ketogenic diets that are around on internet nowadays, which are weight loss, so-called weight loss diets, but one should remember that the ketogenic diet, basically what we are doing is we are shifting the metabolism of the patient. So normally you and I have a carbohydrate-based metabolism. Most of our energy needs are provided by carbs. Fats form a very small percentage of what our energy needs are met through. Whereas in the ketogenic diet, we reverse this ratio. So fats become the major energy need providers. So obviously this has to be done in a carefully medically supervised way, and this leads to what is known as ketosis, and ketosis then leads to improved seizure outcomes. But why does a dental practitioner need to know about the ketogenic diet? The reason is if there's a child on the ketogenic diet, the child cannot take any sugars, any simple carbohydrates cannot be given to this child. So one cannot provide any sugar containing syrups to this child. Not only that, if for any reason we want to use oral dextrose, then that should not be used because oral dextrose is a known pain reliever. So there are lots of research where people provide some oral dextrose to the child and then do slightly painful procedures, and the reaction to them is much better. So that also cannot be used in children on the ketogenic diet. The second modality of treatment is epilepsy surgery. Here again, this is probably the only thing that can cure epilepsy. Here we can surgically remove the area which is the source of the seizures, and this can be found in a significant percentage of children who are having difficult to control epilepsy. The last sort of option in children with difficult to control epilepsy is the vagal nerve stimulator. It's a simple device, although very, very expensive, which has to be implanted in the subcutaneous tissue of the chest. So it can be felt outside, although it's within the body. And then there's a thin wire that goes to your neck and it is wound around the vagal nerve. And this provides small level of electrical stimulation throughout the day at fixed intervals. This device is provided along with an external magnetic band. The job of the external magnetic band is that when it is swiped over the chest, like what is being shown in the picture, when it is swiped over the chest just above the device, it will stimulate the device and cause it to give an extra electrical stimulation to the vagal nerve. And in some children, this can be used to stop the seizures faster. And although most parents whose child has a vagal nerve stimulator will be trained to use the band, but even dental practitioners should be aware that if a child comes who has a vagal nerve stimulator, in case of an emergency, in case of a seizure occurring, swiping the magnet might be helpful. Now, in the last part of the lecture, I would just like to emphasize some practice points. So when a child presents to us in the clinic for dental work, what are the points that one should remember to elicit in the history? So first of all, what is the frequency of the seizures? So is the child having very frequent seizures? Are the seizures almost daily or multiple times a day? In which case, the child is very likely to have a seizure during dental treatment. Whereas other children may be well controlled with anti-epileptic medications and they are very unlikely to have seizures in the dental setting. Again, what are the types of seizures? So understanding the type of seizure is also important. So if a child has a generalized tonic-clonic seizure, that is the whole child starts jerking during the seizure, then that can create problems during dental treatment if the child has it during the dental treatment with lots of instrument within the mouth. Whereas another child may have a very, very simple focal onset seizure where they just see a few lights or they're just twitching of a finger for a few seconds and it stops. Those seizures are very unlikely to interfere with other treatments or procedures. When was the last seizure? Right? Sometimes parents might be overemphasizing or underemphasizing the frequency of seizures. So asking when was the last seizure can kind of guide us better. Also, does the child have any particular triggers for the seizures? So fever can trigger seizures even in children with febrile seizures, as we learned earlier. Not only that, children with epilepsy, that is children who normally have unprovoked seizures, their seizures can also increase during episodes of fever. Also, some children may be sensitive to flickering lights, right? As saw the child in the video, when we put flickering lights into their eyes, she started having jerks. And if we had not stopped those flickering lights in time, the child would have gone into a big seizure. So the dental lights are quite strong, but they're not flickering. So one would say that there's no need. Why would you bother? But the problem is the dentist keeps coming in between the light and the child's eyes. And so even kind of just using a hand over your eyes can cause the lights to flicker. And so some children who will be very sensitive, it is a good idea for them to wear some form of eye shades to prevent the light from falling into their eyes. We should be aware of the medications that the child is taking because medications might be implicating dental treatments. Also, very important practice point is to emphasize that the child takes their regular medications even on the day of the dental appointment. So, missing even a single dose of medications can lead to increased seizures, and so it has to be clearly emphasized. So, by chance, if the child is undergoing a general anesthesia procedure or a procedure that requires nil-per orally for a few hours, one can slightly change the timing of the anti-epileptic drugs, but one should not miss the dose. Also, one should be aware of drug interactions. So while prescribing medications, especially antibiotics like erythromycin or metronidazole, one should be careful that the child is not taking carbamazepine, whose metabolism can be reduced and the levels can increase if given along with erythro or metro, in which case the child will start having side effects because of carbamazepine. Some anti-epileptic drugs, especially the older generation anti-epileptic drugs like phenobarbital, phenytoin, carbamazepine, and to a lesser extent even oxcarbazepine, are enzyme inducers. So many anti-epileptic drugs are enzyme inducers, and they will reduce the drug levels of other drugs, including metronidazole. So while prescribing, one should check the drug interactions because it is practically impossible to remember them. I can remember because I prescribe those drugs frequently, but people who don't encounter children all the time on these drugs may find it difficult to remember. Lastly, I receive a lot of questions about safety of local anesthesia in a child with epilepsy on anti-epileptic drugs. So local anesthesia does not interfere with epilepsy and it does not interfere with anti-epileptic drugs and can be safely used. Meperidine is known to increase seizures, but as a anesthetic agent, I think its use is almost stopping nowadays. So one really doesn't need to bother too much about it. And the very last part of the talk is on acute management of seizures. So this is extremely important. All carers, including medical caregivers, should be well aware of how to manage a seizure in their clinics or in their health providing setups. So the first thing is not to panic. I think that is important because seizures are quite scary to look at, and most doctors would become anxious if a patient starts having a seizure in front of them. So what one needs to do in case of a dental treatment ongoing, one should try to remove the instruments out of the mouth, right? If it is possible, but one should not try to forcibly open the mouth because that can lead to trauma. One should note the seizure onset time because that is important in the later management of the seizure as to how long the seizure is occurring. And then immediately put the patient in the recovery position. The recovery position is basically a safe position to prevent aspirations during seizures, because during a seizure, a person loses consciousness and the chances of aspirations are high. So what needs to be done? The right hand of the person needs to be brought next to their face on the opposite side, and the person needs to be turned towards their left. So as you can see here, the hand is placed on the cheek and the person is turned. One has to hold the thigh as well as the shoulder and just turn the person towards the left. And so the person comes into this position, that is the left lateral position, with the right leg kind of going forward and the left arm also kind of remaining forward. This is a way in which the person is safest from aspiration and the drainage pathway of the oropharynx is most open. So after noting the time and placing the person in the recovery position, one should go on to the next step of management. But here one needs to remember, if the person is shaking quite vigorously, and especially in large children and adults, it may be very difficult to put them in the recovery position, in which case one doesn't need to panic. One should not keep struggling with the patient in trying to put them in the recovery position, but one should wait for the seizure to end and then we can put the person in the recovery position. But most smaller children or children who don't have very vigorous seizures, it is relatively easy to put them in the recovery position, and one should do that promptly. As I mentioned earlier, after placing the person in the recovery position, one should not try to forcibly open the mouth, as sometimes the teeth can be quite tightly clenched. Nothing should be placed in the mouth till the child is fully conscious, and if the seizure continues beyond the 4 or 5 minute point, so if the seizure continues beyond 4 to 5 minutes, or there is significant drop of saturations and the child's lips and face is started to turning blue, one should immediately try to use nasal midazolam to try to stop the seizure. And if the seizure persists for beyond 5 minutes and is not stopping despite giving nasal midazolam, one should shift this child immediately to a nearby hospital or call an ambulance. So the threshold for giving nasal midazolam is 5 minutes, and the threshold for shifting the child to the hospital is also 5 minutes. But if you're giving nasal midazolam, one can wait for the next 1 or 2 minutes for the effect of the nasal midazolam to come. And if that is not happening, then the child should be shifted to a nearby hospital. While shifting, after a gap of 5 to 10 minutes, the nasal midazolam can be repeated. Now, how do we give the nasal midazolam? The method of giving nasal midazolam is, so before I do that, let's just understand how the dispenser is. So this is a picture of the dispenser. You can see it is like any other spray bottle. There's a tube going into the fluid. The fluid is not drawn in this picture, but the tube dips into the fluid. So basically, if we tilt the bottle, the tube comes out of the fluid and the fluid flows away from the tip of the tube. So when we are spraying the bottle, one has to remember that the bottle needs to remain more or less upright. We can tilt the bottle a bit, but if we tilt it too much or tilt it upside down, one would end up spraying just air into the nose of the child. So here, there's a tip, it's a plastic tip that has to be fitted over this dispensing bottle. So it is important to understand that sometimes this mechanism may not be functioning well due to various reasons. Maybe this plastic tip is not fitted properly, or sometimes we have tilted the bottle a lot, or at times the bottle has been lying for a long period and this tube that dips into the fluid is empty. So whenever we start using the midazolam spray, we should hold it upright and spray a few times outside to see if it is sprayed. So after we have sprayed outside, it's a very simple mechanism. It just needs to be pressed downwards. Once the bottle starts spraying properly, then we have to get the child in a semi-sitting position or a sitting position, because as I said, we cannot tilt the bottle upside down. So the child has to be brought in a semi-sitting position by supporting them. The nozzle of the bottle, that is this nozzle of the bottle, has to be then inserted into the nostril as seen in this cartoon. And then we have to spray. How much to spray? The dose is about 0.5 mg per kg with a maximum upper limit of about 5 milligrams. So with most children, they are usually 10 kgs of weight by the time they reach a dentist, because they are usually at least 1 year and beyond. So as a rule of thumb, giving 5 milligrams stat would be reasonable in most children, except for the ones who are less than 10 kgs. Available strengths are 0.5 milligram per actuation, and the other strength is 1.25 milligrams per actuation. So these are widely different strengths, and so one should be aware as to which strength bottle are we having. So we should always keep a midazolam spray in the clinic if we are catering to children with special needs. And this is part of the general sort of emergency care drugs. And if we have used it in a particular patient, then we need to clean the nozzle with warm water and let it air dry. And finally, after we have understood the basics of epilepsy, the basics of seizures, the treatment, the side effects of anti-epileptic drugs, the last thing is, and probably the most important thing that we learned was acute management of seizures in the clinic. So after that, there might be certain situations where a pediatric neurologist consultation or even talking directly to the pediatric neurologist might be helpful. So situations like if the child is having difficult seizures and not getting controlled with medications, then that child certainly should be referred to a pediatric neurologist. And if you notice that there is severe gingival hyperplasia and it might be a good idea to change the anti-epileptic drugs, please do call us, because we being neurologists, our concentration may not be into the oral cavity and we may miss things. And if there were other specific questions that I may not have answered in this presentation and they crop up later on, please feel free to call one of us or our colleagues. Thank you so much.
Thank you, Saurabh sir, for enlightening in the details of the special healthcare children. It was lovely attending the 2-year-long session, and in fact, it was so in-depth detailing about the management of different kind of special child. I hope all the participants would have learnt a lot. So there are few questions that have been asked for your presentation. If you may allow, we can just put in some questions. The later ones can definitely be contacted by you. And I think there are a few questions. Dr. Sanchita has a question. Do provoked seizures require long-term medications, doctor?
Hi, am I audible? I hope you can hear me.
Yes, sir. You're audible, sir.
Provoke seizures,
Yeah.
seizures or seizures that are provoked due to transient electrolyte changes, hyponatremia or hypocalcemia, do not require long-term anti-epileptic treatment. They probably may require short-term treatment for a few days. No long-term treatment is required.
Okay. Thank you, sir. There's one more question from Dr. Khultam. She has asked, in light of your comment on clonidine, would you recommend it over midazolam as the first line choice for ADHD sedation to ensure a more predictable cooperative outcome? Shall I read the question once more? Hello?
Dr. Shikhar, I can't see sir now on the platform. Maybe sir is muted or sir is
Hello.
Sir is there.
uh,
Sir is there.
okay.
Sound is not clear.
Yeah, Saurabh sir, can you hear me?
Yes, I can just about hear you.
Okay, there's one more question. I'll just repeat it. In light of your comment on clonidine, would you recommend it over midazolam as the first line choice for ADHD sedation to ensure a more predictable cooperative outcome?
Um, uh, okay, so in ADHD patients, if they are already on any particular ADHD drug, then one should ensure that they have taken the drug on the day of the dental appointment. Some patients may be on clonidine, some other patients may be on other medications. So, making sure that their regular medication is in place would be helpful. Yes, some patients respond better to clonidine as compared to midazolam, but that may require a bit of trial and error as to which patient responds.
So we have one more question, sir.
Yeah, there's one more question. Sir, could you explain the applicability of nitrous oxide sedation for cerebral palsy patients or in epilepsy?
For cerebral palsy and epilepsy, there is no contraindication for the use of nitrous oxide. Nitrous oxide is contraindicated only in a very, very small and rare group of inverters of metabolism. That is the ones that have B12 metabolism defects or have severe B12 deficiency. Besides, it can be used in all other patients, and it is reasonably safe to use if the dental practitioner is well versed with it.
Okay. Uh, Thank you, sir. I think that is all for the question session as of now. If there are more questions, we will direct them to you for personal answers. And it was really a lovely session, and the knowledge was in depth. Thank you so much for taking out time and sharing all these details to the participants as well as to us also. Over to Andra, sir.
Yeah, thank you, sir. And certificate, please. Certificate for Saurabh, sir. Kindly accept the certificate, sir. Sir. Can you post a certificate for the moderators also? kindly at Chicago, sir, for
Thank you, sir.
a long session, for chairing a long session.
It's always a pleasure, sir. It is
Thank you
such an
so much.
informative session.
Yeah.
Yeah. Thank
But
you.
it was very informative session for all of us. Thank you.
Yes, sir.
Next certificate for Guru. Yeah. Thank you, ma'am.
Thank
for
you.
going-
Thank you. It was really a pleasure. Thanks.
Yeah,
Thank
Thank you. Thank you, ma'am. Thank you so much, ma'am.
Thank you all. Thank you so much.
Thank you. Thank you.
Thank you, sir.
So we are going to the last session of today's program, that is understanding children with cancer, and this is will be taken by Dr. Manjusha, and I would like to call upon our moderators, Dr. Deepa Gurunathan and Dr. Virat. Dr. Deepa is a professor of
Good
pediatric
morning, sir.
dentistry.
Good evening, sir.
Good evening, Doctor.
Sir.
Is a professor in pediatric dentistry and associate dean research at Savida Institute of Medical Science and Technical Sciences. Completed BDS from Tamil Nadu Government Dental College and MDS from Manipal University and PhD from Savida Institute. Published over 150 research papers in national and international journals. Recipients of several national and international awards for the clinical excellence. Serves as editor-in-chief of the International Journal of Pediatrics. Actively trains students and participates in full mouth rehabilitations, orthodontics, and research methodology. We welcome you, ma'am.
Thank you, sir. Thank you for the introduction.
Next moderator is Dr. Virat, professor and head dentistry at AIMS Raipur. Completed BDS from Manipal, Mangalore, and MDS from DAV Dental College, Yamunanagar. Has authored numerous national and international research papers, co-authored the textbook in pediatric dentistry, and holds a patent for custom periosteal implants for maxillary reconstruction. And he is an editorial member of our journal JISPPD. We welcome
Thank
you.
you. Thank you, sir. Good afternoon, everyone.
Good afternoon.
Good afternoon, sir.
Good afternoon. Good afternoon.
Ma'am, kindly introduce the speaker.
We welcome Dr. Manjusha Nair for this program on special healthcare needs in dentistry. Dr. Manjusha Nair is currently serving as an additional professor in the Department of Pediatric Oncology at the Regional Cancer Center, Thiruvananthapuram. Madam has over 20 years of experience in the field of pediatric oncology. She hails from Trivandrum, Kerala. Ma'am has completed her MBBS from Government Medical College, Thiruvananthapuram, under Kerala University. Ma'am also holds a DNB in Pediatrics from the National Board of Examinations, New Delhi. Has undergone training at SAT Hospital, Government Medical College, Trivandrum. Ma'am has obtained a postgraduate diploma in adolescent pediatrics from the Child Development Center, Medical College, Trivandrum. A special interest lies in the pediatric palliative care, and she holds an international fellowship in the pediatric palliative medicine endorsed by RCPCH UK. Ma'am, we welcome you to this program.
Good evening, everyone. I am Dr. Manjusha. I am additional professor of pediatric oncology in Regional Cancer Center, Trivandrum. I am doing this for the first time, this recording. So if there are any technical glitches, please bear with me. I hope it is all right in that. So the topic given to me is understanding the child with cancer. So it is a very important topic as far as special needs dentistry is concerned, because these are really a group of special children who require meticulous dental care and follow-up during and after their treatment to improve the quality of their life. So that much is the impact that it can make. So I'm very thankful that this topic has been included in this series. So coming to, let's start with the parents' words. When my daughter was diagnosed with leukemia, our world stopped. In the chaos of port placements and chemo schedules, a dentist came to her hospital room. He didn't just look for cavities. He taught me how to wipe her mouth with a soft sponge when it was too painful to brush. He showed me what to look for when her counts were low. He was the first person who helped us feel like we could do something in a situation where we were feeling completely helpless. He gave us back a small piece of control. He gave back her smile. So the learning objectives for today's session is to gather some general information about pediatric cancers. They're associated with a lot of myths, so the myths and facts we'll be covering. We'll be covering the common signs and symptoms, how to diagnose, what are the treatments available, and what are the survivals expected. Another point, how does malignancy affect oral cavity and what are the issues and how do we manage? And general guidelines for dentistry in pediatric cancers. And why are we learning all that? So that we want to become that dentist who brings that smile on the face of that child and the family. Some background information of childhood cancer. It is one of the leading causes of death and disability in a child. But in our situation, other reasons are malnutrition, other childhood illnesses, infections, congenital malformation. So actually childhood cancers are rare events. But they are a very frightening group of disease. In the sense, there are many fears associated with cancer. The fear of pain. Cancer represents pain in our mindset. There is fear of toxic treatments, the side effects of treatment, loss of body parts, or even the fear of death of a child. The financial catastrophe that occurs. Cancer treatments are expensive. So many people are fearing the financial distress it causes. Especially in our situations like a low and middle income countries, there is actually lack of awareness regarding where to get proper treatment. You have a lot of hospitals. Some people are doing something, some people are doing something. So you don't know where to go for a proper treatment. So actually, the diagnosis of cancer creates disruption in the life of the whole family. You know that the child is affected with cancer, but the whole family is affected. The parents, they lose their employment. The siblings, because this child needs the parental care. The siblings lose the parental care, the healthy siblings. And their school performances come down. So it sorts of affects the whole family. It is a most stigmatized disease in the sense that a cancer diagnosis is viewed as a death sentence in our society, even in these times. People talk about evil spirits, bewitchment, or some black magic, God's curse, or karma, or something wrong that the parents have done or the ancestors have done. 4 or 5 generations back, somebody has done some wrong and the child is affected with cancer because of that. Like a punishment for a sin, it is treated as some sin or some vastu problem, umpteen causes. And you would be surprised to know that even in the educated population, such misconceptions exist. Families fear social isolation if the diagnosis of the cancer in family is revealed. So they will hide the child's illness from the community. They'll go to other traditional healers. They'll go to everyone but an oncologist. And this prevents them from taking proper or timely treatment so that there is a delayed diagnosis. There is an advanced presentation which will affect the survivors. Some myths versus facts. There is a cultural belief that cancer is related to evil spirits. So whoever is having the cancer or whoever has been treated with cancer, they are still carriers of those evil things and they will pose the health risk to others. While in reality, childhood cancer is not an infection. It is not transmitted by a virus. So it is always safe to interact with the cancer patient or the survivors if there are other children at the house or if there are other people. It's always absolutely safe to interact. There is a misconception that a cancer patient or a survivor is genetically inferior and they will have problems in growth. They will have fertility problems. They won't be able to marry. They can't have children. This isn't true for actually most of the survivors. It is true that some survivors have fertility problems, but this all depends on the type of cancer and the type of treatments. So that is the ones, majority of the cancer patients or the majority of the survivors, they are able to find employment, they are able to get married, they are able to proceed with their studies. proceed with the family life and have children. We have a lot of survivors who have children, and they come to visit us very happily. Another misconception is that survivors have short lives. So there is some inclination towards this number 5. They will live only till 5 years, or they will live only till 10 years. The reality is that 2 out of 3 childhood cancer survivors have, even though they have an increased risk of late effects, the life expectancy is actually equal to that of a child who does not have cancer. There is also this feeling among the even the doctor community that survivors, it's over, so they can just go and they do not need follow-up. Whereas the reality is that continuing follow-up care remains important for survivors because of the long-term sequelae. They can't even have a normal life. They will have a miserable, sad and dismal future. They won't be able to study. They won't be able to get an employment. This is also not true. There is a life and a future after cancer. Most survivors are able to return to school. They are able to, resume their regular activities and effectively reintegrate with friends and family. So it is true that some of them have some cognitive and learning disabilities, but it is also related to the type of the treatment and the age at which the child is affected. Most survivors do very well in their education and career. In RCC survivor group, we have children, we have survivors who are doctors, we have engineers, we have government servants, IT professionals, medical social workers, dialysis technicians, nurses. So any profession you choose and you have a cancer survivor in it. So they do that good. Is pediatric cancer hereditary? So this is a very important question that everyone, just you tell the name of the cancer and hereditary comes to the mind. So the fact is that 99% of the cancers are not hereditary or familial, except retinoblastoma, which is a type of eye cancer found in very small children. Most of the cancers, as we know, are caused by genetic mutations, which are the changes in DNA. So this leads to the misconception that if it is caused by a genetic mutation, it has to be inherited or it has to be familial, which is wrong because these mutations are found only in the cancer cells. They are not found in any other normal cells in the child's body. These mutations, they occurred de novo inside the child's body. They were not inherited by the child from the parents and shall not be passed on to the next generation also. So that there is no increased risk of cancer in the siblings if you have an affected child in the family. Many times parents ask us, if there is another child, do we have to check that child also for cancer? Or if they are planning for another child, so will the next child get cancer? So there is actually the risk for the next child developing cancer is almost the same as that in the general population. Just because one child had cancer does not increase the risk of cancer in the next sibling. Some more myths, cancer occurs because of some infection, sometimes dengue, because after dengue, once after the dengue infection, the child gets a disease. The platelets don't recover and the child is diagnosed with a leukemia. Child gets admitted and the parents think that the dengue caused the cancer, which is actually not true. 2 children get cancer because of any food or medicines the mother took during the pregnancy. No. There was a WhatsApp forward that looking at mobile phones causes eye cancer in children. Looking at mobile phones for long duration can cause so many other problems in children. Learning issues, attention deficits, so many things they can cause, the behavioral changes. But cancer is not one of them. Does living near mobile tower location increase the risk of cancer because of the presumed radiation? The certain types of food like maida, bakery items, sugar, non-veg food, does these cause cancer? No. There is absolutely no link of any of these with cancer. The fact is that childhood cancer, the cause is unknown. We carry these myths because we always compare with the adult cancer. In adults, there is a proven association between these various risk factors and cancer. For example, smoking and lung cancer, there is a proven association. Drug abuse or alcoholism and liver cancer, pan chewing and oral cancer, red meat ingestion and colon cancer, there is an association. so that by making some lifestyle changes and avoiding these risks, we can prevent some of these cancers. But we should never compare the adult cancer with the childhood cancer. They are very different biologically. A number of risk factors have been studied regarding childhood cancers also. There are a lot of studies that have been done studying the age of mother during pregnancy, vitamins, food intake, medicine by the mother during pregnancy, electromagnetic field exposures, pesticides. All these have been studied with reference to their link with cancer. But so far, no evidence has been found that any of these factors cause cancer in the child, which means cancer did not happen because of taking non-veg food, or because the child just played and fell down, or because the child is using mobile, or the child is eating some bakery food. No. It cannot be prevented by changing our lifestyle or food habits. You cannot do anything to prevent a childhood cancer. The only possible thing we can do is to suspect early, detect in time, and treat properly at a pediatric oncology center. So that brings us to the question, how and when to suspect a cancer in child? Childhood cancer is often difficult to detect in its early stages. One thing is they are very rare in it, so that a pediatrician who may see around 20-30 patients every day and practices for so many years may see only 1 or 2 cases in the whole lifetime. It is that rare. And symptoms and signs and symptoms are also non-specific. For example, maximum cancers that we see at our place is the blood cancer. And the signs and symptoms of blood cancer are like a fever or body pain, pallor. So all this can be found in other fevers also. Even viral fever can have the same program. Sometimes they are insidious in onset because, for example, a bone cancer. The child may be complaining of a bone pain for so long. After months only, it gets diagnosed as a bone cancer. So this is because always when the child presents with these symptoms, non-malignant is the first TD, and the malignant only comes when the symptoms are persistent. So even doctors do not like to consider the cancer first, thinking of the bad impact that it may have on the family. There are certain warning signs that have been published. So if these signs and symptoms are present, it does not mean that the child has cancer. It means that they warrant evaluation to rule out or confirm the cancer. For example, pallor, bruising or bleeding, generalized bone pain. If it is persistent, all these symptoms, just because we see one pallor or one bleeding or bruising does not mean that it is cancer. It could still be another non-malignant condition. But if it is persistent and not responding to the normal treatment, then we need to consider that should this child be evaluated for cancer. For example, lumps or swellings anywhere, especially if painless, especially if there is no fever or signs of infection, unexplained weight loss. So there are eye changes like white pupil, new onset squint, or there's loss of vision, bruising or swelling around the eyes. There is an abdominal swelling, headaches. So all headache is not cancer, but if persistent headache, early morning associated with early morning vomiting, limb or bone pains or swellings which are persistent. So all these, we should have it in mind to evaluate for cancer if the symptoms persist. Orofacial masses that can be malignant. You see these 2 pictures. The first one is a swelling of the palate. This turned out to be swelling of a hard palate, and it turned out to be a lymphoma arising from the hard palate. And the second one, the baby you see, it looks like a mandibular swelling, but it turned out to be a soft tissue swelling and was rhabdomyosarcoma. So you can have even head and neck swellings or orofacial masses that can be malignant. What are the common type of pediatric cancers? So broadly, we classify pediatric cancers into 2 groups. One is the hematolymphatic cancers, and the next is the solid tumors. So hematolymphatic cancers, they primarily involve the bone marrow and lymphatic system. These 2 are grouped into one because they are interconnected. So the malignancies affecting the hematopoietic system are called the leukemias or the blood cancers. Most common is the acute lymphoblastic leukemia, which is also the commonest pediatric malignancy. Next comes the acute myeloid leukemia. Then the lymphomas that arise from the lymphatic system, you have mainly 2 varieties, Hodgkin's and non-Hodgkin's lymphoma. Solid tumors are tumors that arise from the organs or part of the organ, so that they present as swellings mostly. So you can have, depending on which organ is affected, you can have brain tumors. If it comes in the eye, you will have retinoblastoma. There is swelling of the adrenal or sympathetic chain. Anywhere in the sympathetic chain, right from the base of the skull to the pelvis, you have the neuroblastoma. You can have liver swelling, that is hepatoblastoma. If it comes in the kidney, it is called the nephroblastoma or the Wilms tumor. If it is occurring in the muscles, you call it rhabdomyosarcoma. Or the connective tissues anywhere in the body, you can have the soft tissue sarcoma. Ovary or the testes or the reproductive organs, you have the germ cell tumors. And the bones are affected by two types of bone tumors, that is osteosarcoma and Ewing sarcoma. So these are the common types of cancers. So how are pediatric cancers diagnosed? So we see these symptoms, these things are persistent, and we think of a cancer and we try to diagnose it. So main concerns are, is it a cancer or not? That is the first concern, because as I told you, even here, first DD will be a non-malignant condition. After that, we think of a cancer. So it has to be confirmed before you start the treatment. So is it a cancer and what is the type? So by histopathological diagnosis, we can confirm this, because even though we group cancer as a general term, as I showed you before in the previous slide, there are a lot of types of cancers. So we have to confirm what type it is. And the third one is where all it has spread. So in that, we do the staging and the metastatic workup, because how this child will respond to your treatment and whether the cancer will be cured will depend on how spread it is or how advanced it is. So metastatic workup and staging is very important. Treatment for malignancy can begin only after the cancer has been accurately diagnosed and extent of the disease has been defined precisely. So what are the tests we use for these diagnosis and metastatic workup? Depends on the type of the cancer. The two broad groups I told you, one is blood cancers, for that complete blood counts and differentials, peripheral smear, and the diagnostic test is the bone marrow examination, aspiration, biopsy, and flow cytometry. For solid tumors, histopathology is the gold standard. You do a biopsy, you see it under the microscope, do the special stainings, and confirm that what type of cancer it is. Other imaging things for the local, knowing the local extent of the tumor are, you can have X-rays, ultrasound scan, CT, and MRI, depending on which part is affected. PET scan and radioisotope scans are used to find out whether it is done with the whole body, so that you can be able to find out where these cancers are, whether it is spread to the other parts of the body. Tumor markers are chemicals secreted by the tumors, and they also aid in the diagnosis. For example, in hepatoblastoma and germ cell tumors, you have elevated alpha fetoprotein and beta HCG. Now, after diagnosing, how do you treat? Pediatric cancer treatment has 4 prongs: chemotherapy, surgery, radiation, and the new one recently introduced is the immunotherapy. As the name suggests, chemotherapy is treating with medicines, surgery is removing the tumor, radiotherapy is using radiation to kill the tumor cells, and immunotherapy is using specific molecules that can target the mutations in the cancer cells and destroy them. But which modality to apply and to which child, it all depends on all the information that you gather from the diagnosis, the type of the cancer, the age of the child, the stage of the cancer, which body part is affected. So whether to give chemo first or whether to send for surgery first or whether to give the radiation will all depend on all these factors. So most pediatric cancers will require a combination of these modalities. For example, the child will require a chemotherapy, then the tumor will shrink, then he will be sent to surgery, and then after surgery, some tumor will be remaining, then radiotherapy will be given. So it is called the multimodality treatment because combination of modalities is applied, requires special skills and trained personnel and equipment. So it is a complicated affair, and even meticulous supportive care is required. It is not enough to just to deliver the treatment and send the child home. You have to meticulously follow up because it is a treatment that is going to have a lot of side effects. So you have to be on watch for the side effects. You have to catch it early and manage the complications so that the morbidity and mortality is reduced. So pediatric cancer should be managed only in a center having specialized pediatric oncology care personnel and facilities. Generally, leukemias and lymphomas, chemotherapy is the main treatment. Chemotherapy duration may vary from 6 months to 3 years, depending on the type of leukemia. And the ALL, I told, which is the most commonest pediatric malignancy, requires prolonged chemotherapy of 2.5 years duration. Coming to solid tumors, again, it has multidisciplinary treatment depending on age, stage, and location. Generally, they have to be treated in both ways. Systemic treatment should be given because if small micro areas of metastasis is there, that should be addressed. So systemic treatment is also required, and local treatment is also required. So chemotherapy is used for systemic treatment and surgery or radiation for the local disease control. And here also treatment duration varies from as less as 4 months to 1 or 1.5 years. So is childhood cancer curable? That is a big $1 million question that everybody is asking. You are taking so much of effort. What is the result? Will the child get cured? The parent will ask you, will my child get cured? So about 50 years ago, majority of the children diagnosed with cancer died. But 5-year survival rates have increased over the past 50 years because of development of aggressive treatments and supportive care facilities. This has led to a decrease in mortality so that 2 out of 3 childhood cancer patients today are expected to survive, not die. And approximately, if you take all the cancers together, the survival is approximately 60 to 80%, 5-year survivals. Of course, they vary between the type of cancer, but this is generally all cancers taken together. Now, what is this 5-year survival thing? So everyone is asking, like, does it mean that the child will live only for 5 years? No. 5-year survival means the percentage of the children will complete the prescribed treatment and are still alive 5 years after the diagnosis. And if a child is alive and disease-free after 10 years after the diagnosis, the child is thought to be cured. So the best survivals are got for early stage cancers. But if it is a disseminated or metastatic cancer or a relapsed or recurrent cancers, then the survivals are poor. And these survivals depend on a lot of prognostic factors: age of the child, the stage at which the cancer is there, which is the histology and biology of the cancer, how does they respond to treatment, and a lot of other factors, the molecular signature of the cancer, so many things. This graph shows the survival over the years, pediatric cancer survival over the years. If you see the lowest one, the blue one, the 1975 to 79, the survivals are so low. That is around 58 or something like that. And as the time passes, the survivals have increased, so that in the last one, the 2010 to 2019, it has reached up to more than 80%. This is collective for all cancers together. Of course, for each cancer, the survival varies. But this graph shows how it has advanced over the years. So what does this mean for dentists? As the children survive more, we have more patients with dental issues to deal with. So we should know what are the issues that these children are going to have and how do we prevent or deal with that. So the next part of the presentation is about oral or dental issues in pediatric cancer. These issues can occur due to chemotherapy, radiotherapy, or the cancer itself. So why is it that cancer therapy affects the mouth particularly? Why are we concerned regarding this? This is because cancer treatments, be it chemotherapy or radiation, they lack specificity. So a cancer drug, when it goes into the body, it cannot differentiate between a cancer cell and a normal active healthy cell. So it will go and kill all the cells that are there in its trajectory, so that the healthy cells also die as a collateral damage. So it affects the most dividing cells in the body. That is why you have hair loss, because hair follicles are one of the most fast dividing. That is why you have the neutropenia, thrombocytopenia, because the bone marrow is one of the most actively dividing cells in the body. That is why you have the oral mucositis, because the oral epithelium, the mucosal epithelium is also one of the most rapidly dividing. So rapid cell turnover is there. So that is why these tissues are at risk. So dental lamina, tooth buds, oral mucosa with rapid cell turnover, salivary glands, alveolar bone, craniofacial growth centers. All these are at risk of damage due to the chemotherapy, radiotherapy, or the cancer itself. What about malignancies and oral cavity? Do you find primary oral cancer in children? No, it is actually a disease of the adulthood. Primary oral cancer is not found in children. But in case of teeth, if you take the case of teeth, dentition is affected in a condition called the Langerhans cell histiocytosis, which even though it is a cancer or not, nobody knows, but it is treated on chemotherapy protocols. Again, in the gums, if you see acute myeloid leukemia or the lymphomas, they can present with gum hypertrophy and gingivitis. Maxilla and mandible, you can have lymphomas or even sarcoma. And the soft tissues of the face, head and neck, you can have rhabdomyosarcoma or the fibrosarcoma. Coming to the treatments affecting the oral cavity, chemotherapy and radiation both can affect. In chemotherapy agents, we use high-dose methotrexate, anthracyclines, 5-fluorouracils. These are medicines that are used in many pediatric cancer protocols, and they directly damage the oral mucosa. In the bone marrow transplant patients, we use melphalan or busulfan. That is also very notorious to cause the oral mucositis. Then certain other chemotherapeutic agents like cisplatin, cyclophosphamide, ifosfamide, they affect the salivary gland and they cause the xerostomia. Orofacial pain is caused by drugs like vincristine and vinblastine. And of course, radiation to the head and neck region will cause oral cavity issues in that area, even both xerostomia as well as mucositis. So oral mucositis can occur, infections can occur, candidiasis, herpes simplex virus, because they are immunocompromised. Dental caries can occur, and if caries are unattended, there is a risk of infection because they act as a nidus of bacterial growth. You can have gingival hemorrhage, which is related to the thrombocytopenia, dry mouth, and taste dysfunction, which also affects the nutrition and the quality of life. So these are the oral complications that we expect during the cancer treatment. So coming to each one, oral mucositis is probably the most debilitating and frequent acute complications. About 60 to 70% of patients will get. So generally we see them after 7 to 14 days after chemotherapy. There will be some erythema of the oral mucosa, then followed by ulcer and pain, which increases to severe pain, which will affect the ability to eat, drink, and even speak. And the issue is that a mucosal breach is also a portal of entry for systemic infection. So 7 to 14 days after the chemo, child is already immunocompromised, and there is a portal of entry for systemic infection also. So the WHO has given an oral toxicity scale to grade the mucositis. So grade 1 is just soreness and erythema, as you can see in the picture. Grade 2 is there is a mucosal breach and there is erythema and ulcers, but the patient can still swallow food. Ulcers with extensive edema is grade 3. So the patient may not be able to swallow the food, but still liquids may be able to tolerate. Grade 4 is so severe mucositis that alimentation is not at all possible. Even the liquids patient cannot swallow. So that is called the grade 4. And this grade 3 and grade 4 are called severe mucositis. How do you prevent or manage the oral mucositis? Basic oral care is the most consistent evidence which has been shown to prevent mucositis. We'll be coming to that later. Then there is oral cryotherapy, that is sucking on ice chips, ice cubes, or flavored ice lollies during the chemotherapy infusion. What happens is that they produce a local vasoconstriction so that the chemotherapy drug is not able to reach the oral mucosa and damage the cells there. Then topical agents like honey, vitamin E, olive oil, aloe vera, a lot of studies are there, conflicting evidences. Some say it is good, some say it is not so good. Anyway, they are agents that are being tried in oral mucositis. Same with the glutamine mouthwash. It is swished and swallowed so that the oral mucosa is protected. Then upcoming thing is low-level laser therapy or the photobiomodulation, in which you apply the specific wavelengths of light to the oral tissues. You started before the chemotherapy and it is done daily till about 7 to 10 days of chemotherapy where you expect the maximum tissue damage. Promising evidence is there. So here also some studies show that it is not so good, but now upcoming studies, recent studies have shown that there is a promising evidence, because at least the grade 3 and 4 you can reduce and just you can curtail it at grade 1, grade 2 level, so that the nutrition of the patient and the pain are not affected, both of them, which is contributing to the quality of life. So not recommended are the chlorhexidine mouthwash because it is an irritant to the mucosa. Chewing gums and topical growth factors like Clasentress, they are currently not recommended in the guidelines because they are not found to be very effective. What about dental caries? Dental caries, avoid elective restorations while on active cancer treatment, and we focus on emergencies only, and we can schedule the elective restorations to after treatment. Even in case of attending to the cavity, drilling or the root canal treatment, they increase the bleeding or infection risk. So that is also scheduled probably after treatment. Dental extraction can be done. Even a traumatic restorative treatment also can be done. But make sure that the absolute neutrophil count and the platelet counts are within the range. So you have to coordinate with the onco team, and it has to be planned in between the chemo cycles. I'll come to that in the later slide. And actually, there is no contraindication for local anesthesia for the dental procedure because we frequently get the request for clearance for local anesthesia. Actually, clearance for local anesthesia is not required if the counts and platelets are okay. Now coming to the tooth development. So if we notice at the tooth development, we see that most of it is completed before 30 months or before the 3 years. So the age at treatment is the most significant risk factor for developing a dental defect later. Because children who are treated at less than 3 years of age are at the highest risk for dental defects like the microdontia, tooth agenesis or tooth defects. And even the treatment type also affects, because if you have a concomitant radiation and chemotherapy, in some protocols, the chemotherapy is going on at that time, you have the radiation therapy also. So that increases the risk of dental caries and root malformations. And the younger the age of the child and the higher the dose of the chemo or radiation, the more severe are the sequelae. So how do you manage? What is the role of dental care in pediatric cancer, care? If you see, it is a very comprehensive role. It starts even before the treatment. So even before you start the treatment, you assess the risk, you screen the oral cavity, you give the proper dental treatment, caries prevention. During cancer therapy, the complications, what all we have discussed just now, manage those complications. After the treatment, you have to keep the patient under check, caries prevention, dental treatment, and dentofacial orthopedics, routine preventive restorative care. So it's a very comprehensive role. So pre-treatment dental assessment is very important. So ideally, even 2 to 4 weeks before the initiation of the treatment, when you are planning for the chemotherapy, so how can you plan this? So when you suspect a cancer and you know that the histopathology will be ready by around 10 or 14 days, and you know that this is highly likely to be a cancer, the ideal timing is you send to a dental visit at that time. The goal is to eliminate any sources of infection, stabilize the oral health before the immunosuppression sets in. So you have this window period in which you can actually do the procedure and stabilize the oral health before the child goes into the immunosuppression. And always education of the family is very important. So the essential component will be a comprehensive clinical examination, assessment for caries, periodontal health, any existing restorations, any orthodontic appliances there, because if you are planning a chemo which is highly likely to produce a severe mucositis in the child, it is best to have the appliance removed. So always consultation with the oncology team is required. There has to be a shared care, a collaborative care, and the family has to be educated on dental hygiene and oral care, because if we don't educate them, it remains a neglected area and later the child presents with a severe infection. So education is as important. Pre-treatment interventions, what you can do before the cancer therapy starts is, if there is a non-restorable teeth or advanced periodontal disease, or there is an impending exfoliation, you can extract it. If there is active caries, restorative treatment can be considered before the immunosuppression sets in. Fluoride varnish is recommended for all patients, but I have never seen it applied even in our setup, so I'm not sure about that. But the scaling and prophylaxis, if there is a lot of residue, sediments are there. So scaling and prophylaxis can be done so that the future cleaning and keeping in oral health, future oral health is kept better. And as I told before, the appliance removal if you are planning a high risk of mucositis therapy. Pre-procedure safety check. So if you see this graph on the right side, once a chemotherapy is given, so you see this, this is the graph showing the WBC count. If you pay attention, the WBC count goes down, starts going down by around day 7. And there is a nadir that is reached at around, day 10 to 12, probably 10 to 12, 9, 10, 12, 11, 12. And after that, the WBC count starts rise. And then at the next chemotherapy, you will be planning probably at around day 21, day 18 or day 20. So this window period of neutrophil recovery is there. If you want to plan any procedure, you will get the safe parameters at this point. That is absolute neutrophil counts of more than 1,000 or platelet count of more than 50,000 or hemoglobin of more than 8. So you will get at this point. So always be in collaboration with the oncology team when they are planning chemo and when to expect a safe neutrophil recovery window where you can plan the procedure. So during treatment, as I told earlier, oral care protocol is mandatory. It's the most important thing for preventing both dental problems as well as oral mucositis. So daily home care can educate. Frequent oral rinsing with saline or sodium bicarbonate is very easy to make. You can even educate the parents to make the saline at home. They have to dissolve 1 spoon of, 1 spoon of common salt to be dissolved in 1 liter of water and can use it, or the soda bicarb washes also. Betadine wash, chlorhexidine wash, those are all not required. If there is any area of oral thrush, then we advise to use the clotrimazole mouth paint. Otherwise, routine clotrimazole mouth paint is also not required. Lip lubricants are important because dry lips can again lead to cracking and oral mucositis. So Vaseline or any lip lubricants are good enough. Ultra soft toothbrush or foam swabs can be used for cleaning the areas between the teeth or brushing for the daily brushing. Non-alcohol, non-flavoring mouth rinses can be used, and adequate hydration is very important to maintain the oral health. Generally, children, they eat in between and they do not wash the mouth. So we encourage them to rinse the mouth after each meal. Whatever, if in between also child takes a half a biscuit or half a peanut chicky or something like that, we tell them to rinse the mouth to keep the oral hygiene good. Then professional care, regular monitoring every 2 to 4 weeks, fluoride applications, it's recommended, and treat emergent infections aggressively. So the key principle of oral care is to minimize the trauma and maintain the hygiene. What are the long-term dental sequelae after treatment? So most prevalent long-term sequelae will be enamel alterations like hypoplasia, or even in these dental sequelae, long-term sequelae will also depend on the age at which the child got the treatment and what is the dose of the treatment got. So hypoplasia, opacities, microdontia, dental caries, increased prevalence of caries, periodontal disease, salivary alterations, root abnormalities, short, tapered or missing roots, missing teeth, craniofacial growth disturbances, especially if you have a radiation to the face, or altered bone density, which causes changes in the mandible. Up to 75% of cancer survivors, pediatric cancer survivors, have these dental complications on long-term follow-up. So how do you monitor them? Regular clinical reviews every 3 to 6 months, and then panoramic radiograph for defect detection. If after 1 or 2 years of follow-up period, we can even periodic radiographs we can take. Modified dental defect index for recording the defects, and monitor for caries, periodontal disease, or any new developmental defects and correct all those defects that are occurring. An important area is transition of care because pediatric dentists should ensure a smooth transition to general dentistry practice for long-term follow-up because they require years and years of follow-up. So there should be a smooth transition after they become an adolescent or the adult group. Practical tips for dental professionals who are working with families of children with cancer: be sensitive to time constraints because cancer diagnosis, as I mentioned earlier, it's something very big the family has to take on. They have to manage multiple medical needs. So if you are very rigid on your appointments, you are very rigid on your advices, then it will not be followed. So be sensitive to time constraints. If some cancer patient is coming in the OP, it's better if you don't make them wait because they may have planned some other procedures and also that will be very helpful for them. Actively include parents in care decisions because you need to tell them what to expect. You need to tell them what complications are expected. And a decision should be a shared decision rather than a paternalistic, we are making a decision for them. And be flexible in scheduling the appointments. Educate the parents on looking into the child's mouth to recognize normal versus abnormal. This is something that we do often. Because each time the child comes to the OP, in a busy OP, it is very difficult to do a comprehensive oral examination for every child. So we educate the parents to look in the child's mouth, see if they are seeing anything abnormal to alert us. Brushing twice daily with soft brush and fluoride toothpaste. Rinsing after sugary medications. Even rinsing after each small meal, each in-between meal also, rinsing is advised. Avoid sharing the utensils to prevent bacterial transmission and limiting sugary snacks and drinks for good dental health. Communicate freely with physicians, nurses, and feeding therapists. Recommended sugar-free medications whenever possible and advise on fluoride sources and preventive measures. So summary and key messages. Children with cancer are special need patients requiring a coordinated, individualized care. Cancer therapy causes both acute and long-term oral complications affecting teeth, mucosa, saliva, and bone. Age at treatment is the strongest predictor of dental developmental defects. Dental management occurs in 3 phases: pre-treatment, during treatment, and post-treatment or long-term follow-up. Always it should be a collaborative treatment. Communication with oncology team is essential so that the patient care is safe. Cancer survivors need lifelong monitoring for late effects and regular dental recall. And pediatric dentists are critical members of the team. So cancer treatment is a teamwork and pediatric dentist is a valuable team member. So thank you for giving me this opportunity to speak on this topic. And I would like to take any questions.
Thank you, madam. And it was a very nice presentation, taking care of all the pediatric dentists, highlighting all the basic oral care. And I am not seeing any questions in the chat box. I hope you have made it very simple and easy to understand. So probably everybody has understood nicely. Over to you, Dr. Anandraj.
Yeah, thank you, ma'am, for that lecture. I think you have covered most of the pediatric, this one also in this one, the fluoride therapy, all those things which rarely we will get from medical people. So thank you so much for that. Certificate, please, ma'am. We don't have any questions so far.
Sir, can I just ask ma'am one question?
Yeah, sure.
Ma'am, it was a very informative session. Like small things were also looked into. I would just like to know, like whenever we take children for general anesthesia, the anesthetist is a little bit apprehensive of if it comes to any child with either leukemia or Even if it is in the initial stages to take under GA, they are a little bit apprehensive. What are the things that we have to look into when we take a child with any type of cancer to undergo a GA or any other pharmacological methods of management?
Dr. Anand,
Yeah.
ma'am is there in the platform because
Yeah, she's there.
okay, maybe she need to unmute herself. I don't know.
Ma'am, Manjusha ma'am?
Yeah. Yeah, am I audible?
Yeah, yes, ma'am.
Yes, absolutely.
Thank you. Yeah, thank you for that question, ma'am. It's really a very good question. Actually, we get a lot of this question from our other specialties also. So, as far as leukemia is concerned, it is a continuous treatment. So, actually, there is no safe period in which you can give a general anesthesia. If you see the cutoffs and all that is mentioned for the general patients. But for leukemia patients, we need to bring that cutoff a bit lower because you cannot expect a normal blood counts in these patients till they complete their treatment. So what we do is, as I showed, if absolute neutrophil count is above 1,000, if the platelet counts is above 50,000, some people prefer 75,000. If the platelet count and if the HB is above anything above 8 to 9. Then it is safe for a general anesthesia. If the chemotherapy that is given immediately before is not a very aggressive chemotherapy, probably we expect that child to recover in another 1 or 2 weeks. So that is the time when it is safe for the general anesthesia or for any procedure, because always healing is also affected by all this immunosuppression if you do a procedure. So that has to be done in that nadir in which you expect a good neutrophil count. So that is why I said it is because protocols vary among different cancers also. Even if we say that it pediatric cancer means it's not a simple. For some solid tumors, the key.
I can't hear, ma'am.
Voice is gone.
Maybe some network issue is there.
Yeah.
We have one more question also in the.
Yeah, one more question has come up. Ma'am, can you hear?
Manjusha ma'am?
Ma'am is connected, but she's not.
Probably some connectivity issue.
Am I audible now?
Yes.
Yeah, so that is what I was telling. So that is why you generally we ask them to coordinate with us when to expect a good neutrophil recovery so that the procedure can be planned.
Okay.
Ma'am, one more question
Otherwise,
has
that
come.
there is no special precautions. But for children who have received anthracyclines, so there is a risk of a cardiotoxicity. So we ask them to get an echo done before the general anesthesia or the procedure.
Okay.
One more question, please. It has come. When to advise salivary substitutes? How to decide upon intervention the level of hyposalivation?
Actually, it's a very difficult question because these are growing children. So we actually keep them under follow-up. So if it is very severe, only then these methods are advised. Some of it we see that if they recover like 2 years, 3 years down the lane, some of the salivary functions actually recovers after the radiotherapy also. So those children, they don't need. But it is always good to keep them under follow-up. There is no general guideline like that, but it is always good to keep them under follow-up and intervene when it is required.
Okay, ma'am, that's all the questions.
If the same case, sorry to interrupt, sir. Ma'am, if it is the same case in an adult, what to do, ma'am?
Adult, actually, I am not very sure. We deal only with children. Adult is a totally different scenario.
Thank you.
Dr. Pawan, that's a very good question that whenever there is a hypersalivation and do we need to advise salivary substitutes? Yes, whenever we feel that saliva is not there, because we know that saliva has a very important role in digestion as well as keeping the dental tissue in good condition. So we need to start um, substitute for sure. That is for sure. And other than that, as Dr. Manjusha has already, very clearly mentioned about the use of fluorides, multiple time rinsing, and especially when the child is eating or taking some sugary preparates. So for everything, she has already covered about the brushing. So I think we need such kind of oncologist for our population of India, and it can make really a lot of difference because I have seen that most of the oncologists, I'm sorry to say, Dr. Manjusha, they don't advise many things for the dental problems, right? Either they don't even refer the child for dental management. But if the child is managed right from day one about the dental problems like use of fluorides, frequent rinsing, keeping the oral hygiene good, it will save the child from multiple dental issues. It will be really making a lot of difference in child
Yes,
quality
even
of
in the hospital visits, number of hospital visits, the
Yes.
preventing a complication is always cost effective than dealing with a complication.
Yeah. I was really happy
And
to
it increases
hear.
the quality of care that you provide also. And the parents there, our parents especially, if you tell them, they're very compliant. Regarding a children, if you tell them something, they're very compliant. So
Fully
it is very easy to, Only thing is doctors should stress that. Otherwise, they just neglect it. So if we stress and tell them, mostly they're very compliant. Even the oral examination, our mothers, they will tell us like there is a spot. Even the hard palate spots, which we really miss on even looking at the oral cavity, they will tell that there is a spot on the hard palate up there. Then they'll show us, see doctor, there is that spot.
Yes.
So it's how you educate them, it carries these things. We actually in medicine, we become obsessed with the medications and all, but these are factors that really make a difference.
Absolutely, ma'am. Absolutely. And this is very important. This will really improve the quality of life of the patients.
Yes, and the world is going in such a way that you introduce this photobiomodulation even before chemotherapy, so that the grade 3 and grade 4 oral mucositis can be curtailed to grade 1 or grade 2. So that the child will have less pain, the child can have more nutrition, and your further treatment is, it even impacts survival. See, a severe oral mucositis, which hampers the nutrition, it's going to delay your next chemo cycle because you can't start it till the child recovers. And then in final, in the long run, whether it impacts your survival, you never know. So if you are able to prevent that, you are actually impacting the survival.
Absolutely. Absolutely. Wonderful.
Wonderful
Thank you so very
lecture,
much.
ma'am.
Thank you
It
so
was
very much.
it was a very, very informative lecture. And just what we really wanted, you have touched on all those aspects. I'm really very happy that you were there in the evening session. The session was so good. I must compliment both the speakers because we were just glued to our devices. Very nice. Thank you so much.
Thank you. Thank you so much.
Thank you, ma'am.
Can we have the certificate for ma'am? Kindly accept the certificate, ma'am.
Thank you. Thank you very much.
And the certificates for the moderators. Deepa, ma'am.
Thank you, sir. Thank you, everyone. Thank you.
And for Virat, sir.
Thank you, sir. Thank you. Thank you, everyone.
So as we come to the end of today's session, I would like to take a moment to thank each one of you for being such an active and enthusiastic part of this program. We hope today's discussion, ideas, and shared experience have been useful and inspiring. More than anything, we hope you take back something practical that you can apply in your day-to-day practice. Most of the things what we have learned today in the evening session, we can do in our practical, in our day-to-day practice also. Thank you once again for your patience, your energy, and your willingness to learn and grow together. Let's meet tomorrow morning at 9 a.m. sharp for the next session. Have a pleasant evening.